At Gilead, we have been committed to delivering person-centric advances in HIV research for more than 35 years. Our latest innovation spotlight will focus on the concept of drug resistance. Drug resistance can impact the selection of treatment regimens and is an important area of our long-term HIV treatment research. HIV drug resistance is caused by mutations in the genetic structure of HIV that may affect the ability of medicines to block the replication of the virus. All antiretroviral drugs, including those from newer drug classes, are at risk of becoming partially or fully inactive due to the emergence of drug-resistant virus. Today's treatment regimens are highly effective at lowering the amount of HIV in the body when taken as prescribed. However, the virus may be resistant to treatment for several reasons, including past treatment failure due to resistance development, challenges with medication adherence, or acquiring drug-resistant strains of virus. If HIV does begin to replicate once again, the virus may also gain the ability to evade certain medicines that were previously effective. This creates the potential for development of resistant strains of the virus that may be passed on to others who also may now have fewer effective treatment options available to them. Drug resistance is a key area of focus for our long-term HIV treatment research. Scientific discovery will have the most significant public health impact in minimizing the effect of HIV drug resistance on the global treatment landscape and get us one step closer toward the ultimate goal of ending the HIV epidemic for everyone, everywhere.
People often say, everything is fine. But then again, they also say things like, we're loving this. And, great idea, boss. Then there are those who reply, looks great. Or say, close enough. They tell themselves, I'm all right. I'm all right. Still all right. While others answer, so good. Some respond with, I can make it work. And every so often they say, that's nice. Then there are moments when people say, this will be okay, even when they think it won't be okay. So when people say everything is fine, is it?
At Gilead, we have been committed to delivering person-centric advances in HIV research for more than 35 years. Our latest innovation spotlight will focus on the concept of drug resistance. Drug resistance can impact the selection of treatment regimens and is an important area of our long-term HIV treatment research. HIV drug resistance is caused by mutations in the genetic structure of HIV that may affect the ability of medicines to block the replication of the virus. All antiretroviral drugs, including those from newer drug classes, are at risk of becoming partially or fully inactive due to the emergence of drug-resistant virus. Today's treatment regimens are highly effective at lowering the amount of HIV in the body when taken as prescribed. However, the virus may be resistant to treatment for several reasons, including past treatment failure due to resistance development, challenges with medication adherence, or acquiring drug-resistant strains of virus. If HIV does begin to replicate once again, the virus may also gain the ability to evade certain medicines that were previously effective. This creates the potential for development of resistant strains of the virus that may be passed on to others who also may now have fewer effective treatment options available to them. Drug resistance is a key area of focus for our long-term HIV treatment research. Scientific discovery will have the most significant public health impact in minimizing the effect of HIV drug resistance on the global treatment.
Hi, everyone. Hope you enjoy your lunch. Today, our conference will be structured actually in three big sections. So the first one is like the mental health, the second one is physical health, and the third one is the social health in relations to sexuality. So this morning, we have a lot of like discussions, lectures is on the mental health section. So this afternoon, we'll continue with the physical health section. So the topic for the coming few sections is the igniting vitality, the intersections of physical health and sexual well-being. So we'll focus on the crucial aspect of sexual health within the wider context of overall physical well-being. So our first speaker is Dr. Lisa Yip, and Dr. Yip is the public health physician and has a great passion of philology. So she is currently the Senior Medical and Health Officer of the Special Preventive Program overseeing the HIV surveillance team and the Red Ribbon Center. So her topic is what is combination prevention, looking at HIV, STI from a biomedical, structural, and behavioral perspective. 有請葉醫生。
Oh, thank you. So hello everyone. So my topic will be combination prevention. Actually, combination prevention in preventing disease is a very common approach for many diseases. A good example will be the cardiovascular disease, such as you have to practice a healthy lifestyle, healthy diet, have more exercise, and no smoking, etc., to prevent the risk of cardiovascular disease. And for certain cancer, you have to, there may be, apart from the lifestyle modification, you have to, the screening and also some of the vaccine. So in the context of the HIV prevention, actually, from the UNA's prevention reference group back in 2009, they have already defined the combination preventions. There are two key keywords. One is combination, meaning that's the use of a mixture of interventions, such as which can be grouped into biomedical, behavioral, and also the structural interventions. They should be composed of the, which constitute the right-based, evidence-informed, and community-owned programs. Another keyword is the prevention. So this mixture of the programs should have to achieve the greatest sustained impact in reducing new infection. However, in order to achieve the greatest impact, one should be this intervention should be prioritized to meet the current HIV prevention needs, tailored for the particular individuals and communities. That means one should know your epidemics. So what are our epidemics? So up to 2003, end of 2023, we have already 20,038 HIV reports received, and over 2,400 of them has already progressed to AIDS. So comparatively, Hong Kong has a relatively low prevalence of 0.1% among HIV prevalence amongst the general population as compared with the global population of 0.7%. And we have the concentrated epidemics. As you can see, the prevalence is much higher amongst some of the priority population or the key population, notably as MSM, which have the 6.75% of HIV prevalence. So looking back for the past 4 decades, when since 1984, when we have the first reported HIV cases in Hong Kong, the epidemics gradually grows and which rapidly rise. Which rise until the turn of century, reaching the peak of 700 at 2015, and then gradually, with upon the wide adoption of the test and treat strategy, and resulting in the effect of the treatment as prevention. The number of cases, HIV cases reported every year has decreased for the past 8 years, representing 45% drop. However, whether it's sustained, we are not quite sure. You can see that for these X consecutive years, the drop is only 2.9% in the last year. So the challenge is that whether we can sustain our effort to make the drop further. So let's look a bit closer look on our epidemics as maybe since what accountable for the drops. So in terms of basic demographics, the gender, you can see that the main drop is due to the male. In contrast, the female drop is more moderate. So if you compare with the peak in 2015, there is around 50% drop in the male cases, whereas the female cases only 30% drop. For the case of age, you can see that the main drop is concentrated around the relatively young population, ranging from those aged 20 to 49. However, for those greater than 50, there is, in contrast, a paradoxical increase. So our intervention should also tailor, apart from continue our efforts to concentrate to target to the young population, we also need to focus on the older population. Regarding the route of transmission, all along over these 40 years, all along the route of transmission through the injecting drug use is relatively low level, you can see. But for the heterosexual, you can see that there is a quite flat in the past 2 to 3 decades. The number of cases is around 100 heterosexual cases reported each year. And for the MSM, you can see that it accounts for the majority of a drop. And so the drop is even more prominent among the MSM as compared with the overall drop. As mentioned by Dr. Bonnie Wong this morning, apart from the figures, we also need to have the composition of these HIV cases. One of the observations is that there are increased proportion of the late presenter. We can see from the slide, you can see that the as manifested by those with newly reported case, when they newly first diagnosed of HIV, when their CD4 count is less than 200 cells per mil, which according to WHO is already fall into the definition of advanced HIV cases. So in the past 20 years, it's around half of these HIV cases belongs to the late presenter, and it's further improved and then followed by improvement until the 2014 fall to 28%. But unluckily, it's in the past few years is gone back. It's reverted to around half of them. Half of the newly diagnosed HIV cases are actually late presenter. Another way to look into late presenter is that look into the number of HIV AIDS cases reported. AIDS cases represent a very late stage of HIV infection without treatment. So you can see that in the last year we have around 100 AIDS cases reported, which is increased compared with the 2022. So you can also notice that in the preceding years there are quite a sharp drop in the number of AIDS cases. While the pattern, we need more time for observe to make a concrete conclusion for the underlying cause. Inevitably, the COVID impact is have this can be a very important contributing factor for this, which there may be the link in the affect the linkage to care and as well as the accessibility of HIV testing. So, and just a reminder that vast majority of AIDS cases actually presented without HIV diagnosis before. That means that when they first have the HIV test is that when they already present with AIDS-defining illness. So, so this is room for improvement already. So for the our epidemics, it is still characterized by the concentrated HIV epidemic among MSM. And we have very good progress in decreasing the number of new infections, especially amongst young MSM. But we have still some challenge in whether we can sustain our success in further decrease the number of HIV cases, and there are some issue of the late presenter. So back to sustain, back to our questions, how to sustain the further decrease, I think is the answer is the combination prevention. So the combination preventions is can be categorized into a very broad categories about medical, which using the antivirals to reduce exposure, transmission, and infection. Examples including the treatment as prevention, preventing the MTCT, also some medications, antiviral to in the context of pre-exposure and post-exposure prophylaxis. It also includes the behavioral approach, such to promote individual risk reduction, including the traditional condom use, uptake of HIV testing, to education, to social marketing, especially for the Youth Equals to program. Go beyond is the structural, is address the barriers, to minimize the barrier, eliminate stigmas, and to promote an embrace environment. So in our local context, we have the recommended Hong Kong recommended strategy which orchestrate the coordinated and consolidated response on local HIV control for the next 5 years. As mentioned by Dr. Ho, we have vision, the 3-0, and also we put much great emphasis on the HIV prevention, as well as the 95 treatment targets. So we would like to have 10 quantifiable targets to be achieved by 2026. Now is 2024. So let's see some of the progress. So this actually the targets is well designed, which includes some of the biomedical indicators, including the treatment prevention, the 95, and also the prevention of the MTCT to achieve 0 new infection among locally born children. And for the biomedical measures such as pre-exposure and post-exposure prophylaxis, it is integrated into one of the indicators as the HIV combination prevention services accessibility. So, as mentioned before by various speakers, we have already, for the 95 treatment targets, thanks to the contribution of the Sandy Holt Center for Emerging Infectious Disease of Chinese University of Hong Kong, which construct the epidemic model using the Spectrum software. So we can see that at the year of 2020, we have a good achievement in the first 95 and also the third 95, but little bit not so good in the second 95. That means the those on treatment, those among the diagnosed with HIV infection should be put on treatment. Only 84% of them are put on treatment. So for the progress, you can see that we have since 2012, we have good progress in reporting and on also the ART, but not the little progress in care. So the linkage of care, we should do more. For the pre-exposure prophylaxis, let me share with you our PISM survey, which is an HIV and behavioral survey amongst the MSM and TG conducted in 2022. So among the sexually active MSM without a prior diagnosis of HIV, positive HIV diagnosis, 23% of them have ever used pre-exposure prophylaxis. In contrast to a similar survey conducted in 2017, only 3% of them have ever used PrEP. So for the current PrEP user as defined as the usage of pre-exposure prophylaxis within 1 year, it is 18.3%. So for the pattern of the usage, around 40% of them use the on-demand PrEP, which is the most common method of practice of the using PrEP. And for the source of PrEP, the online usage is the most common method. So let's go to the behavioral. Some of the indicators as highlighted red are concentrated on the condom use. Another one indicators is, one of the targets is the uptake of the testing as highlighted blue. So, but before looking into progress, I would like to highlight one of the policy brief last year issued in June last year, yes, concerning the counseling behavioral intervention. So actually, WHO summarized the 9 RCT to see the effectiveness of this counseling behavioral intervention, which with the primary or the sole aim to change behavior, whether the change of the institution of counseling to change behavior can actually change behavior, or even the incidence of STI and something, and HIV. But they after the summary they have not shown that it is not shown to decrease the incidence and risk behavior. But this is not useless. But in contrast, if the counseling and information sharing, but not aimed to change the behavior, just you share the information, it is a variable key of components to engage the priority population, but this should be carried out in a non-judgmental manner. And also WHO highlights that those counseling interventions that promote absentees and promote the conversion therapy are not recommended because it creates further barrier. So the implication for as a rapid event center and other service provider is that actually WHO is not against you to integrate the counseling for the behavioral intervention. In contrast, when you decide to include this component in your program, you should bear in mind the potential limitation and the cost. And also, the counseling intervention per se are variable, has some additional benefit. One is the engagement. Another is the develop rapport and building caring relationship between the service provider and the recipient. So the figures comes to figures. So the condom use, we compare the 2017 to 2022 figures in the condom use. You can see that there are drop in the percentage of condom use across different types of sexual partners among MSM. However, as you all know, PrEP usage is associated with decreased condom use. So for fair comparison, we have excluded, further analyzed using, after excluding the ever PrEP user. However, you can see that the drop is still exists according different types of sexual partners. So the condom programming should be continued and enhanced. How about the testing behavior? You can see that for the HIV testing, there are slight improvement. Around 50% of them have testing for HIV within 12 months. For the STI testing, there are prominent, very substantial improvement of HIV STI testing within 12 months. And I would like to take this opportunity to especially thank all of the NGOs, because where they perform the testing, actually 40% of these HIV testing are conducted and offered by NGOs. So you can see that this figure is thanks to the HS Fund to give us the figures. These are the number of voluntary testing and voluntary counseling and testing by NGOs as supported by the NGOs. You can see that in the around 2019, around 1,000 testing will performed every month. However, there is a significant drop over this 2020 to 2022, obviously due to the COVID. So I highlighted some of the we call the local waves, so first, second, third, and fourth. You can see that every time there is a wave, there is a drop. And also the most traumatic wave is the fifth wave, which occurred in the first half of the 2022. So the first wave drop. But the NGO is very good. You can see that upon the resumption of normalcy, the testing volume is quickly climb up again. So to further enhance testing, our department has an initiative since last November. So everyone can, apart from the key population, everyone, you can order free testing kit from the websites. So we hope that this initiative can further decrease the barrier and enhance the testing. So taken together with the combination access to combination prevention, which is one of the quantifiable targets. So one of the quantifiable targets is that 90% of the key population, including MSM, should at least have 2 items of HIV prevention service. So for individual items, the accessibility within 1 year is varies from 12% to 60%. And in combination, only 60% of the MSM has access to two more items in the last 1 year. So very far behind of the 90%, which we need to catch up. So for the behavioral, there are in the previous slide, I deliberately dim some of them because this is not included in the quantifiable targets. However, this is no less important because it is already mentioned in the key strategic area, including the sexual education, HIV education, etc. For the structural, it is the stigma and discrimination reduction. It is also very important, as mentioned in one of the key strategic areas. So in the PRISM survey, we also touch on the discrimination, but due to time constraint, we will not go into details, but just that the discrimination and stigma problem is still a very important issue affecting the sexual minority. So despite various campaigns and various workshops for the target to the healthcare professional, etc., we will continue our effort, yes. And also we have another initiative launched this year, the Commons, which is a one-stop service with providing comprehensive and holistic HIV prevention care services to MSM. So our colleague, Dr. Lisa Do, will have an introduction on them. So in summary, so there is no one major bullet of the HIV prevention intervention is not a single one can be sufficient to control the whole epidemic. So in other words, we have to combine it to achieve the greatest sustained impact. But beyond I think the combination prevention go beyond the combining the intervention. You should be combining our effort. So for the HIV prevention, we have many stakeholders, government and the non-government, etc. So we have to involve the whole society to have the concept, collective, organized effort for the HIV prevention and care. So as mentioned in one of the key strategic areas to mobilize the collaboration between the government and the wider society. So this is the last slide. So there is a Chinese saying, 40 八劃. That means when one individual has arrived the age of 40, he or she should be certain, no doubt on the philosophy and the principle and all the identity of oneself. And take an analogy, we have 4 decades since the very first local the HIV reported case in our Hong Kong. This is 4 decades. So I think we have certain on several things. One is that the ending AIDS as a public health threat by 2030 is possible. This is not a slogan. We also know that there is no single prevention strategy sufficient to control the HIV epidemic. We also sure that the combination approach is the key, and also the collaboration, the combining all the effort to make the dream come true is also the key. So thanks for your attention. Thank you.
Thank you, Dr. Yip. Thanks for giving us an overview of combination prevention and remind us all about the progress of our efforts so far. 今次我哋聽咗好多係啲故事啊 story 嘅，頭先葉醫生就好多數字嘅，不過我覺得數字 is also a form of language, and it's just like it started the conversation to explore more behind what's happening behind the numbers. 所以我覺得有啲數字我哋 remind 下而家狀況都好好。So I'm going to invite our next speaker, Dr. Winston Goh. So Dr. Winston Goh is a family physician who obtained his medical degree from the University of Hong Kong and did some overseas training in United Kingdom as well as United States. And Dr. Goh has a particular interest in the healthcare education for the LGBTQ plus community. So he formed the Hong Kong LGBT Medical Society with the mission to promote gay, lesbian, bisexual, transgender healthcare and education in Hong Kong. So the topic that he's going to share today is effective strategy to promote sexual health among LGBTQ plus community. But I know that he bring in a different, cases, come to share with us, like how we can put into practice some of the ideas on sexual health promotion. Thank you, Dr. Goh.
Hello, everyone. Thank you for AIDS Concern to allow me to talk about some clinical, cases. This is more kind of like a sharing of my, the practice that I have in Hong Kong. I don't have fancy figures, but from my perspective in the ground level, I try to share with you what I see, on a day-to-day basis. So hopefully you guys can get a glimpse of what we see, in the day-to-day in primary health care. So the goals is to, for me today, is to share with you how to optimize sexual health and well-being amongst the LGBT community and the community at large, and to demonstrate some effective clinical strategies I found to promote sexual health and well-being in all patients. So I'm going to share with you two cases. So case one is a 26-year-old Indonesian man who came to see me just last month, complaining of, quote, an anal discharge for 2 days. He was worried about a so-called anal fissure. So right off the bat, when someone comes and describes these terms that are quite medical, I would wonder how did he learn these terms. So actually a year ago he presented with a similar complaint to an outpatient clinic, not with me, and was prescribed an antibiotic. So of course he already had some knowledge of what was going on, but of course he was concerned and wanted me to verify that. He had, upon questioning, a past medical history of generalized anxiety and was taking some anxiolytics, Xanax as needed. He has no history of drug allergies. So, some of the things that primary care physicians were very good at doing is just, sitting back and observing, being aware of so-called nonverbal cues. So the gentleman was an office worker, very well dressed, but during the whole consultation, he was avoiding eye contact. He only spoke when I asked him, so he was quite quiet. And on physical examination, his blood pressure was quite high at the offset, 150 over 100, and heart rate was quite fast at 90 beats per minute. After sitting down, I asked him to take some slow deep breaths. Clearly, he was anxious, so that allowed him to kind of calm down and really gather his thoughts so that he can, give me a good history. So I didn't waste too much time, and I asked him, so what, tell me a little bit about your sexual history. And what he shared was he had receptive anal sex with condom 1 week ago with a casual male partner. And he noted some, quote, pus discharge from his anus. So obviously that was the real reason why he wanted to see me. So my job was to kind of, figure out what exactly this discharge was about. So during the physical examination, he appeared quite anxious. I asked for a consent to have a chaperone with me, so that because this is a very sensitive examination, really required someone there to give him some peace of mind. So on examination on the outer anus area, I didn't see anything, no obvious redness, rashes, lesions, or any sinus tracts. And then I had to use this little device we use at the office called a proctoscope. So this is a tool we use sometimes to clearly look at the inside of the anus, and this can cause a little discomfort. So whenever you counsel patients, you have to warn them this could be a little bit uncomfortable. So when I inserted the proctoscope, I did not see any tears, any fissures. The anal lining was completely normal. And then lastly, I had to do we call digital rectal examination to actually feel the inside of the anus, so that I couldn't, to make sure that there's nothing else in there, and there were no obvious masses, no blood or pus noted. So my working diagnosis at that time was, the presenting complaint, a perianal discharge. And on top of my mind, there were some of these things I had to make sure that this patient did not have, namely an anal fistula, which can present with a purulent or serosanguinous discharge. Other things could be a pilonidal sinus, which are also things that can cause this kind of complaint. There's also some skin lesions like sebaceous cysts that could also present with that. And then finally, he mentioned about anal fissure, which is actually a tear in the lining of the anus. So luckily for this patient, there was none of these serious conditions that I could identify in the gentleman. And the treatment for him really was reassurance, telling him that there really isn't anything too serious. He did not require any antibiotics. And I obviously told him we should continue to observe. But the things that he needed to be aware of is the next 2 points: patient education and opportunistic screening. So it was important for me to make sure that whenever he engages in sexual activity, he is nice and relaxed, because I think what was probably happening was he was very anxious, and without proper relaxation, when you engage in anal sex, you could cause a lot of trauma, discomfort, even some kind of mucus discharge from there. So it was important to educate him, like, okay, you need to be prepared mentally before you can engage in this type of activity. And then the second thing is really opportunistic screening. So this was a great opportunity to really start discussing about certain things. So this gentleman is a gay man or MSM population. And the important things we need to highlight is sexual health screening. When was the last time he had any STDI screenings done? Was he aware of his HIV status? Even though he mentioned he was wearing condoms, you cannot be 100% sure that was always the case. So it's important that anybody who comes into the office with a sexual health complaint is aware of their HIV status, and asking him whether he's heard of PrEP, and discuss so-called high-risk sexual activity, the risk of contracting HIV, and lastly, vaccinations. So this gentleman actually has taken PrEP before. In fact, he's taken before, and the biggest issue for him was that he was having back pain, and so he stopped taking it. So for us as primary care, it's important to be aware of patient's ideas, concerns, and expectations. We call ICE. He really was, the reason why he stopped was he was worried that it could have caused his kidneys to be damaged, and that's why he stopped taking it. So my job was to address those misconceptions, and clearly PrEP if taken properly, is very safe. And if he was worried about his kidney, we could check his kidney function and to make sure it's okay. But with him being high risk of contracting HIV, it was important to counsel him why is he not taking it, and that he should be taking it, and having access to it is important. The second issue is taking a proper sexual health screen. So his last health screening was 6 months ago, so it was important to discuss about repeating an HIV test, running other things like a syphilis screen, and doing a swab for gonorrhea and chlamydia if necessary. And then also discussing, what constitutes high-risk sexual activity, meaning having multiple sexual partners, having receptive anal sex without a condom, and also discussing, things like needle sharing and drug use, because all those things can increase your risk of contracting HIV. Luckily, he was a patient who said you always use condoms during sex, and he did not have any history of illicit drug use, so that is a protective factor in a way. The other thing to bear in mind is hepatitis. You can also get STDs, not just the ones that are common, like hepatitis A and B. He wasn't aware of his status, so we had to check his antibody levels, make sure that he has protection, and then lastly, vaccinate him for monkeypox and meningitis, because the MSM population also has that risk. So for this case, the main key learning points is that LGBTQ patients frequently carry a lot of anxiety and shame into the office. They frequently hide their sexual orientation and gender identity due to social stigma, and this is something obviously we need to work better at changing. And so they feel embarrassed, obviously, talking about things that have to do with sex. So as a clinician, our job is to make sure that they feel comfortable, opening up to us, so we can make the proper diagnosis, being extra sensitive to this particular population. Ask open and closed-ended questions skillfully. That's always not very easy to do if you're not used to doing it, but if you do it more often enough, you will know when is the most appropriate time to ask direct questions and when to ask more kind of general questions. And always see taking the time to really listen to them first, and use the appropriate language, because sometimes some language can be quite sensitive, and patients may feel a little bit offended. So always avoid being sounding judgmental. Okay, so that's case number one. Case number two is a gentleman. He's a 34-year-old heterosexual Caucasian man. The reason why I chose him is because we always talk about LGBTQ, but we mustn't forget the general population as well. We have people who also have risk factors. So this gentleman came to see me last month complaining of a left groin swelling for 2 months, and he was worried that the groin swelling was related to HIV infection. And upon questioning, he told me he had unprotected oral sex with a female sex worker in Thailand in December, and he did wear condoms during vaginal sex, and he didn't engage in any anal sex. So these are some things that I ask universally to any patient who comes in, even though he's straight. You should still ask them whether there's other types of sex you can engage in, anal sex or vaginal sex. So it's not something just because someone is gay doesn't mean he doesn't do other types of sex, and that's just because someone is straight, he can also do other things. Anyways, so this gentleman, he was quite smart in terms of because he was worried about HIV post the encounter, he actually immediately took the post-exposure prophylaxis for 1 month. He took the pills that he got from Thailand, and then after he finished taking it, a week later, he actually went to get an HIV test to make sure that he was truly negative. But still, he was still worried about possibly getting HIV from that groin swelling. So upon further questioning, he did a full sexual health screen at the Adventist Hospital, which is one of the private hospitals here in Hong Kong. And then they also got an ultrasound scan and found that the groin swelling was a lymph node, it's an enlarged lymph node about 1 centimeter in size. This gentleman, he's from France, so he actually had a GP in France and who he communicated with, who recommended doing some blood tests, including a blood count, liver kidney function, testing for Lyme disease, brucellosis, viruses like CMV and Epstein-Barr, TB and sarcoidosis, just to figure out what's the cause of that enlarged lymph node. And he also recommended the patient to do a CAT scan to make sure, to figure out what was going on to the groin. So obviously when he presented all this information to my office, I was like, oh, okay, let's step back and think, do we really need to do all these tests? What is really going on? He was obviously also worried about cancer, because if you Google internet enlarged lymph nodes, cancer is obviously one of those diagnoses. So coming in, he was very, very anxious, and he had all these issues he wanted me to answer for him. So first of all, as a clinician, there are systematic ways to figure out what was going on. After getting a proper history, the next step is to do a proper examination. So on examination, when I examined his groin, indeed there were some small mobile lymph nodes that I could feel in the groin area. The one he was talking about was on the left side of the inguinal region, and it was a little bit uncomfortable when I tried to feel the area. But actually, on both sides, both the left and right side, he had these lymph nodes. So, but the patient only was aware of the ones on the left side. The next thing to make sure is to figure out whether there could be any local infections that could be giving rise to these enlarged lymph nodes. So I examined his external genitalia, had a look at his lower limbs, and there was no obvious skin infection or skin lesions. So again, my working diagnosis at that time, enlarged inguinal lymph nodes. These were the various differential diagnoses I could come up with. So firstly was, could it be some local infection of the skin and soft tissues? Could it be some lymph nodes that were reactive to a recent sexually transmitted infection that he caught? Could it be cancer? Could it be some autoimmune condition? Could it be some sort of viral infection or some drugs? Was he taking some medications that could have caused the swelling? And then lastly, these rarer things that, like amyloidosis, sarcoidosis, those are, way down the line. But what is the most likely, or what do you think is the most likely cause of these enlarged lymph nodes? Well, it turns out these lymph nodes, when I reviewed all the tests that he provided for me, he actually went to Adventist a month ago and did a bunch of tests. The urine that he did actually was tested positive for this little bacteria called ureaplasma. Okay, so ureaplasma is not one of these common things that people talk about. Chlamydia, gonorrhea, HIV, syphilis. Those things are something that many people talk about. But these rarer organisms are also prevalent in the community. And then the doctor, at the hospital said that, oh, this is something you don't need to treat because it's a common bacteria. And it is true. Ureaplasma is a species, is part of the normal genital flora in sexually experienced males and females. But when you present it with symptoms, it's something that warrants treatment. And for this gentleman with the enlarged lymph nodes, I thought it makes sense that this could be the cause of his enlarged lymph node swellings. And ureaplasma, and just like mycoplasma infections, they have been associated with various genitourinary infections, non-gonococcal urethritis, and also complications for pregnancy. So what did I do with this patient? The management, I treated him with a course of doxycycline for 1 week, and I repeated the HIV test because, of course, he was still concerned, but that was not obviously the top diagnosis I was thinking about. And most importantly is counseling him about safe sex. The fact that he went to Thailand and to engage in that was really the underlying reason that brought all upon all this anxiety. And of course, I followed him up in a month to make sure that the lymph node swelling comes down. And rather than doing all these blood tests and CAT scans, it made sense if it was still enlarged, we could obviously do an FNA biopsy of the lymph node just to make sure there's nothing too concerning. So the case learning points for me in this particular scenario is patients' perceptions of illness may not always may be different from what the doctors think. Factors that influence someone to seek healthcare include various things, socioeconomic status, sex, psychosocial distress, chronic symptoms, and anxious patients may consider some minor complaints to be very life-threatening, while other patients who are very stoic may tolerate extreme pain without admitting ill health. And the point is, presenting complaints may not be the only most important problem requiring the doctor's attention. What I mean by this is, someone coming in for, especially this patient, with a lymph node, on top of his head, obviously, he was worried about HIV. But for me, it was more important to kind of educate him that, yes, that's what you're worried, but you have to take a little bit look about your behavior, how we can mitigate and decrease his future risk of contracting other STIs. Of course, HIV is one thing, but if we could, counsel him and change his behavior and help him in the future so he wouldn't have to present in such a manner. And finding out patients' underlying health concerns and reasons for consultation helps to avoid unnecessary costly investigations and helps to tailor-made your treatment plan to the individual patient. Effective strategies to foster sexual health and well-being. I split those in two parts. From a patient's perspective, is to demystify misconceptions and destigmatization. So, everyone knows, HIV is still a very stigmatizing condition. So, our job is to kind of relay people's fears and educate them and tell them to, really look into how to prevent this illness. Of course, reducing the number of sexual partners, use protection, vaccination, health promotion. Those are strategies that Dr. Yip was mentioning about, and I think we still need to continue to talk to our patients about these. But we cannot change the way people behave, but what we can do is to educate them and explain to them the importance that sexual health is a vital part of their overall health, and knowing one's HIV status is like knowing the your heart rate, and how these are important things that everyone should be able to have access to. And then from a practitioner's point of view, I think teaching and training is important. Being able to teach the younger generation of doctors about how to take a proper history, how to approach these issues, understanding that the LGBTQ plus community have some unique health needs, and then whenever you have the opportunity to be proactive, not just deal with the presenting complaint, but also do some proactive health screening. And lastly, I think integrating sexual health into existing primary health care services can help to kind of offset some of the load that some of these clinics, these busy sexual health clinics are doing. So if primary care, I know primary care has a lot of things they have to do already, but if more and more general practitioners are able and adept to take care of these things, I think that having better access is always a good thing for our community. So here's a little bit about the LGBT Medical Society on the right that Nita was talking about. This is a society that I co-founded with a few other colleagues here in Hong Kong in 2018, and it's a space to really allow clinicians, whether you identify yourself as LGBT or if you are an ally, if you're interested in discussing about LGBTQ health, this is a space for you to you get to know people and how to promote and destigmatize LGBT health. Yeah, thank you very much.
Thank you so much. Thank you, Dr. Goh. Originally, you see, when we set the topic, I'll just highlight cases for the LGBTQ plus community. But as I discussed with Dr. Goh, maybe we should add, like a heterosexual case. I think it's a good idea. In fact, I think the cases that Dr. Goh just mentioned is the cross-border, having sex, like with a sex worker in Thailand. It did happen in Hong Kong. Some of the cases that we also encounter in AIDS concern. So I think it's good you bring us that case up. So it's not just whenever we think of like HIV or high risk, we just think of like MSM. Actually, sexual health, awareness of sexual health is everyone should do that. So thank you, Dr. Goh. Okay, for the next section, I'm very excited about next section because I will be involved, talking with Dr. To. So we will have Dr. Heather To today. So our topic is co-creating an integrated sexual health service for men who have sex with men and transgender community. So you see the word co-creating. So I will not just let Dr. To talk alone. So we will have like a chit-chat dialogue, myself and with Dr. To. Maybe I'll give you some background about Dr. To. Dr. To is an infectious disease specialist currently working in the Special Preventive Program, Department of Health, Health. Besides providing HIV treatment and care to individuals attending the Kowloon Bay Integrated Treatment Center, she is also attending clients with risk for HIV infection in the Yau Ma Tei Integrated Treatment Center. So this Yau Ma Tei Integrated Treatment Center is provide one-stop comprehensive clinic prevention. So we are going to talk about how we can join hands and co-create an environment for the community we serve. Welcome, Dr. To. 我哋兩個一齊坐，你可以用呢個㗎，定係你會中意呢個？我用坐喺度。應該佢哋睇到嘅，不過你好高喎。我今日啲 speaker 全部都好高。Okay, maybe I'll start first. Like why we come with this topic. If you see the banner outside, starting in 2019, AIDS Concern started a service called My Place. At that time, our vision is really hope that we can create an inclusive, safe space for people who need some comprehensive sexual health service to come for help. I remember at that time, it's also because of ATF, have the funding, issues of the heterosexual community, and we've been thinking different ways to address the community needs. That's why we come up with that idea. And when I see the project, like the comments and all the new initiative, I found that, oh, wow, I really like the idea. That's why I keep email Dr. Bonnie and Dr. To saying that, actually, I think it's a really good idea. And I think our vision is really aligned and see how we can create a space that people will come to for the service. So I'm so excited to have this dialogue with you today and have a chance that we can get to know more about the Yau Ma Tei ITC and also as well as the Commons. So yeah, maybe you can introduce us, like what's this Commons is about, what's the vision behind, yeah.
So thank you for the kind introduction. Let's just dive into about what we're doing at the Commons. So the idea that we're doing is actually creating a space that is trying to make it safe for people who would like to come in for some sexual health or counseling or help or etc. Why we come up with the name that we want to make it accessible to all? In Chinese, this is called 一同. So it's like walking together, striving together to create a space that the community will feel it safe to come and ask questions, to bring in the concerns. And later on in the chat, we can share a bit more about what we see in the clinic. Especially, a lot of times, it's actually they don't just come in with questions related to sexual health or other STIs, HIV infections. The first few cases that I saw, they asked me anything that they want to ask. So it's really a space we want to create for them to come in one stop to get health education, health counseling, and also leverage the gap between sometimes they may feel difficult to go around and seek help and ask questions that may feel less comfortable to ask outside the community itself. So before we dive into the exact service, let's see a little video that we prepared promoting our service.
咩話？做性健康檢測都有三高？
係喎，都成3個月冇做 test 啦。
早晨你好啊，想問而家可唔可以上嚟做 test 呢？好啊好啊，咁我而家上嚟啊。
想做檢測得，隨時預約檢測時間。
你填嘅資料我哋都收到啦，而家咧去留個樣本再交翻嚟就可以離開㗎啦。
樣本即場化驗，最快仲可以同日約見醫生，了解自己嘅健康狀況，效率提升100%。Hello， 呢度嘅環境仲好舒適添。中心提供高自主、高私隱、高效率嘅性健康檢測服務。從今日起，一齊輕輕鬆鬆建立持續做性健康檢測嘅習慣啦。
So, as you can see in this little video, we're trying to create a space that is very efficient and a lot of privacy. Trying to address sometimes that the patients may feel a bit embarrassed to talk about, to share the teeny tiny details about. So a lot of times we use a lot of questionnaires and stuff so that they can fill in on themselves, so they can break the barriers of being embarrassed and so on. So who are we trying to serve and who are we targeting? Eligible persons who are above 16 years old of age, or MSM in the transgender population with an elevated higher risk of HIV acquisition. These are just some sort of factors that we find may suggest a higher risk, but of course it's not always limited to all these sort of criteria. And we will also provide sexual health education, sexual health counseling, and also PrEP support to people that are using it. We are not prescribing it, but then if they come in and ask us how to use it, how to get tested, what sort of test they need to address, and we provide all the tests that is needed, and we also give them all the education that they need when they want to use it safely. And this is a service on referral basis. So we were engaging all the community stakeholders, all the NGOs and different partners in the society to refer cases that they think would be suitable and they need our service to us. And as saying in the video, it is a very self-motivating, administering service. So a lot of times the clients, they have their own choice to decide whether they want to come in just for screening or whether they want to also see a medical doctor, medical practitioner for consultation as well. But of course, between the times, we will arrange them to have a detailed assessment just to see how are they doing and give appropriate counseling and support as well. And all the STI screenings are performed by themselves. So they will be given the test swabs, and they will we'll teach them how to collect the samples. And then after they collect the samples, they can just leave it back with us in the clinic. And we have, again, I show you the video, we have tests that's available in our clinic itself. So for chlamydia and gonorrhea, we'll test it in the clinic. So the quickest is that they can get the result within the same day, and we will send them WhatsApp so that if they want to, they can come in as soon as possible to get treated. So it's trying to enhance the efficiency and also make it, because sometimes we have people, our experience, they will have a bit of concern like, oh, I leave the swab with you, when is the result going to be available? That waiting time can be a bit of difficult for the clients. So that's sort of things that can speed up the waiting process to make it a bit more sort of addressing the concerns in a quicker, more timely way. And as said, we will offer regular follow-up for clients that are using PrEP, arranging them for regular coming back for HIV, STI screening, and also when needed to check on the kidney functions, and et cetera, et cetera. And for those that may also, because of other various reasons, need regular follow-up, we'll also arrange it for them. And we will have a clinical psychologist in our team to be, the service will be, commencement will be announced later on, hopefully to also provide a bit more mental health support to the community as well. Because as Lisa was mentioning in her very first talk in the session, this sort of combination prevention comes in many different ways. It's in behavioral support, it's in biochemical support. So and a lot of like discussion, education, counseling, and a lot of times we learn a lot from our clients as well. Like what is their concern? I always like to ask them what is actually going on outside, because we need to know what is going on in the community for us to provide the most sort of targeted and on-point support to them as well. So this sort of place is trying to bring in the synergy from the community, from the NGO, and also from a point of view of the clients to really try to synergize the effect, to bring in that combination prevention, trying to bring it from theory into real practice. And for clients that were unfortunately diagnosed with HIV, we also will initiate ART for them in the Yamate Integrated Treatment Center. So they don't have to go through all that wait, like I got the diagnosis, so how long do I have to wait to see a doctor? How long do I have to wait to actually get treated and get started on the treatment? So in our center, we will also offer that opportunity for them to get hold of the antiretrovirals as soon as possible, just to elevate the anxieties. And also our nurse and doctors will address the concerns when they first get diagnosed and try to address the anxiety as well during the consultations. As said, this is a place that always need support from our community. So we have made this sort of referring system, which is open to a lot of NGOs. We actually have some sessions briefing with the community stakeholders as well, invite them to come in, and Anita was there, and we were like sharing how to try to improve the service. And we is one of the very, we have a WhatsApp, so we always welcome the community to actually tell us what is your sort of feedback to us. So we mainly communicate with the community stakeholders with the WhatsApp, and also if, let's say, the clients, they were tested positive for STI, we will try to contact them by WhatsApp as well, trying to make it a bit more friendly in a way, not like a traditional style of clinic that is always by telephone, like, hey, who are you? We are calling from the Department of Health. We're trying to break that sort of image with our new sort of service. Of course, this is very new to us, so we always, this is, and it's a way that we work together. So we welcome all the other comments from the community. So if there is anything you guys want to refer cases to us or whatever, feel free to shoot us a question on the WhatsApp, and our colleagues will try to get back to you guys. So I don't want to make it too long, so we can leave a bit more time to discuss on things.
Yeah. And you know, the reason why I really enjoy, you know, sharing by Dr. To and, you know, join the briefing section is that, you know, I do agree that it's like a learning process. So we pilot, we learn all the way through, and we can learn together as well. It's not just like the government, but for the NGO, for the community as well. So I think the first questions that probably we can talk about is, so we have the comments now, and so we have all the NGO partners, you know, community people so here. So yeah, maybe we can talk about like how we can synergize, you know, you use the word like synergy. So how we can synergize, you know, the collaborations between the Commons and the community group and NGO like AIDS Concern. I know we have the referral form now, and then we have the communication tool, we have the WhatsApp, we have the referral form. But is there more ways that we can, you know, because I think the service user have a journey. Is there any way that along the journey, anything that we can like join hands together? Any thoughts on this, Dr. To?
I actually have an experience that I really want to share how we can do this together. There was a case that I actually saw in Kowloon Bay Integrated Treatment Center. It's a gentleman who was diagnosed with HIV by the self-test that Lisa has introduced earlier in her presentation, the HIV testing service that we were providing. But then after he got the test result positive, he was very anxious. He arranged the blood taking, the formal HIV screening in our testing center. But while he was walking around waiting for the time to come up, he was so anxious that he called the NGO. And then the NGO was really very providing a lot of on phone support to him, and was like counseling him, talking to him, explaining to him what is happening and what he has to anticipate, and eventually invite him to do the blood test at their center to confirm diagnosis. I think as Nita was mentioning, a lot of times it's a bit of journey going around here. The client may got tested somewhere and got the preliminary results, or got an uncertain result or whatever, and then sometimes in the community, a lot of stakeholders that is here today walk together with the clients until they go into the next step. So, and sometimes for us, we maybe see the clients in our clinic, offer some sort of health advice, and afterwards they went back to the community, but then they would also go and share in the activities that different NGOs are organizing, or sometimes they may have other issues that would need support by the NGO as well. It's not a service that is only supported by one particular stakeholders, but it's always together. We sort of patching up one and each other's gaps, and make sure during the journey the clients is walking through, whether it's about the testing, whether it's about the symptoms, whether it's about the STIs, or whether it's about HIV, they can go to different ways, different parties, and get the questions answered and get their concerns being addressed. And I always believe sometimes they may prefer to ask this question in one particular place and then the other question in another particular place, which is perfectly fine because we all have our differences and preferences. But then it's because all these sort of resources is available in so many different settings, so they can pick and choose where that they feel comfortable. And this is how we sort of let them also have an idea to go around and choose what they think most comfortable with.
So you, the case that you just shared also remind me, because I know that you will have like the clinical psychologist ready soon. But I in the model that we just shared this morning, mental health, we have different ways of like intervention or support. Like meeting a clinical psychologist is one thing, and there are other mental health program, as well as like counseling, support, etc. This is what like some of the NGOs actually they are also providing those services, and there may be some way that we can synergize. And sometimes I always think that you have a space now, and then we can like any way that, for example, like some service or can deliver, you know, like in the comments, and so it's more like a mutual. So it's it will be because when I brainstorm about these questions, I just start thinking about, it's not just about like check-up or testing. It's really about the mental health support, which is, I think many of the NGO, they do have the talents doing that. So this is the area that I think we can also explore.
Yeah. This is the vision that we were having when we built up the Commons as well, is not to position it at just a clinic. It's to position it as a space that can really allow like different stakeholders to come together and work together, and also like something that maybe is the expertise of different NGOs. Then they can have a space to provide it to the clients, and the checkup, maybe just the test. It's just I think the test is just really part of the whole prevention. It's not the major meal. It can be the starters or dessert, but then the whole big piece is always needed different people to bring it all together.
Yeah. Thank you so much. I'm aware of the time, you know, because we've been overrunning the program. So thank you so much. I think this is just like a dialogue, like what Dr. To said, you know, you got the WhatsApp, you know, everything. And then I know that they will continue. Sometimes we'll have the community tour to visit the Commons as well. So, and also you're welcome to come to my place and, you know, like wherever in the community. I always think the most important thing is there are options for the service user. Some people say that, the Commons is like the government service and, you know, like things like that. But I think it's their option. There are different options for people to choose. And so thank you so much, Dr. To, for sharing with us, you know, the Commons, and, you know, thank you. So we're going to have our next speaker, Dr. Grace Lui. So now we are, for this section, we talk about physical health, you know, in the context of like sexual health. So what Dr. Grace Lui we're going to share is aging with HIV, implication and the evolving care needs. And I'm sure that many of you who work in the HIV/AIDS and LGBTQ+ field, you can see the aging issues, just like in general in the Hong Kong populations. So what are the emerging needs of this group, like especially for the aging PL/HIV, and what are the intersections of like HIV and other issues of aging? So I will have Dr. Grace, you know, to do the share with us. Dr. Grace Lui to share with us. Dr. Grace Lui is presently an honorary associate professor and the head of division of infectious disease at the Department of Medicine and Therapeutics, the Chinese University of Hong Kong. And she is currently running a comorbidities clinic for people living with HIV in Hong Kong, and has served in local advisory and scientific committees for the development of policies involving HIV and other infections. Welcome, Dr. Grace.
Thank you very much, Anita, and thanks for inviting me to this very important conference. So what I'm going to talk might be a bit different from what we have been hearing today. So Nida and Heather has been talking about a learning process when they started a new service. For me, as an infectious diseases physician, obviously working on aging for my clients is a learning process for me. I'm not expected to have this training, and while working in this area, I've actually learned a lot together with my clients. So for today, I'm hoping we are going to do a few things. So first of all, I understand that we are all coming from a very diverse background. So we will just talk very briefly briefly on what do we actually mean by aging. And for people with HIV, do they really age at a more rapid pace than the general population? And secondly, of course, we are talking about how aging actually means for our clients, and that would obviously lead to the third very important topic for today. What does these all have in terms of implications on our healthcare provision? So first of all, what is aging? So of course, when we are talking about aging in health, we are not just talking about chronological aging, not getting older year by year through the calendar years, but we are talking about biological aging. So in fact, for our body, we have a very sophisticated system to maintain a balance. So that's what we call homeostasis. So in terms of all the cells, tissues in our body temperature, our blood pressure, the hormone systems, etc. Everything in our body actually maintain a very good balance all the time. And also we have very efficient repair systems whenever we have both external and internal stimulus causing changes in our body. So as we age, these abilities actually get impaired because of aging. So if you look at the diagram on the left, the blue line on the graph represents the situation for the general population. So as we get older year by year, in general, we do have biological aging in proportionate to our chronological age. However, if you look at the orange line on the top, it represents people getting infected with HIV. So at the time of infection, there would be an accelerated rate of aging. However, with treatment, so that's the arrow in the center, with antiretroviral treatment, the line was actually pushed from the orange line to the red line below. So obviously, with effective treatment, the rate of aging would actually be pushed down nearer to the general population. However, because of the initial acceleration in aging, even with treatment, there is evidence that aging is accentuated in people with HIV, even with viral suppression. So, of course, this diagram here is a very simple representation or summary of many of the studies performed in the area of aging. And in the laboratory, in clinical research studies, there are actually a lot of markers, what we call biological markers to represent aging. The example of this study here is just one of the examples. For example, we can measure aging in the brain using very sophisticated MRI techniques. This example here, one of the studies using MRI to measure the micro changes in different areas of the brain, and these changes would represent aging in the brain. And they compare people without HIV, people with HIV not yet on treatment, and also people with HIV on treatment. And you can see from the diagram on the right, the different colored lines there. It's very similar to the graph on the last slide showing the relationship between the chronological age and also biological aging in the brain. And you can see that people with HIV without treatment, they have a larger brain age gap compared to the general population. And this gap is narrower for those who are on treatment. So, of course, the impact of aging is not only in the brain. So this study very nicely showed using different markers to represent cardiovascular disease risk and cognitive function and other inflammation markers. And again, it very nicely showed that people with HIV or at risk of HIV actually do have a correlation between aging. In this particular study, they used the telomere length, which is some part of the chromosome, to represent aging. And again, very nicely showing that aging actually can be manifested in all these different organ systems. So with that, it is not surprising that for people who do age more quickly, they would have some sort of clinical manifestations. And what are these? First of all, there are a lot of comorbidities, or what we call chronic diseases, that are related to age, meaning that they would have a higher incidence as one gets older. So if you look at the graphs here, the bar charts here comparing people with and without HIV. For example, if you look at the bar for those without HIV on the right, for those aged greater than 65 years old, if you look at the pattern of the bar here, you will see that it's very similar to the people with HIV in the age group 55 to 59. So the different shades of gray here represent the number of these age-related comorbidities among the population in these different groups. So it's a very nice and sort of a easy to understand picture to let us see that people with HIV generally age around 10 years earlier than people without HIV, as represented by the number of age-related comorbidities. So they do have onset at a younger age, and also at a younger age, they would have multiple comorbidities. And other than these very well-defined chronic diseases, people, if they do age earlier, they would tend to have what we call geriatric syndromes. So geriatric syndromes is not something we as an infectious disease physician think it's easy to understand because it's not a very well-defined disease like a stroke or hypertension or diabetes. Rather, it represents some constellation of symptoms which are common in older people. And also it is multifactorial. It can be due to a lot of different factors, and also it might involve different systems. So here are some of the examples of geriatric syndromes. And of course, I'm not going to go into these one by one, but just to give you an example. For example, cognitive impairment. So when we are talking about memory impairments in older people, very often we think about dementia or Alzheimer's disease， 即係以前叫老人痴呆症啦，而家我哋叫認知障礙症啦。However, whenever a person, especially an older person, complain of some memory impairment, memory complaints, it really doesn't mean that they have dementia or Alzheimer's disease. It could be due to things like depression, or sometimes when people, older people, they have some acute illness, for example, influenza or an urinary tract infection, they can become a bit confused without actually having infection in the brain. So sometimes it could be medications. People with older people sometimes having a medication, symptomatic medication for colds and flus, they actually can develop some changes in their mental state. So whenever a person have cognitive impairment or some mental state changes in the older people, it can be due to different factors. So that's what we would observe for people with geriatric syndromes. And of course, tackling these problems would be less straightforward. We have to have a very comprehensive understanding of what's going on for that particular person at that particular moment. And another very characteristic geriatric syndrome is what we call frailty. And you can look at the definition as shown here. And the diagram here, mainly, I would like to let you know that although there are a lot of different ways to define frailty, the one I've shown here is a very classical definition of frailty. So in general, we have to measure things like gait speed, grip strength, among the other domains or parameters. And you can imagine that in a routine medical clinic or an HIV clinic, these won't be the things that we will be monitoring routinely for our clients. Therefore, this actually poses some of the challenges that when we are actually tackling the problem of aging in people with HIV. Another important aspect is that having these comorbidities and geriatric syndromes actually would have impact on their quality of life. This is one of the studies we've done in our clinic at Prince of Wales Hospital. So sarcopenia is loss of the function and also the mass of the muscle as one gets older. And importantly, the prevalence of sarcopenia was actually very high among our clients. And what's more important is that people who have sarcopenia or severe sarcopenia had actually worse health outcomes, including problems with mobility, problems with their usual activities of daily living. So this means that having a monitoring system and to detect the presence of these geriatric syndromes would be very important in their health outcomes. And of course, I cannot refrain from mentioning the impact of double stigma between HIV and also aging. So people who get older with HIV actually may encounter new or compound problems because of the coexistence of both issues. For example, they do have worse physical or mental comorbidities because of aging and because of HIV. And sometimes disclosure of HIV status becomes an issue. After years of infection, when they do have new comorbidities coming in, they might require hospitalization because of various reasons. The disclosure problem to family and close members who have been unaware of their status for years might become an issue again. So these very practical scenarios would bring up these issues of stigma again, even after years of diagnosis. Of course, not everything is negative. There are also observations that as one age, they actually have better mental health, better ability to tackle new issues when new problems in terms of physical health come up because of the experience in managing a chronic disease for a long time. So what does all this bring at the end of the day is that in terms of the healthcare service delivery, for both the individual and the community at large, the issue of aging would actually have implications on what we are providing and also what our clients actually need. First of all, early initiation of ART, that's very important. And studies, for example, the START study, SMART study, et cetera, have all shown that early initiation of antiretroviral therapy not only improve immunity and reduce AIDS-related complications, but it also reduce non-AIDS-related complications and all these chronic comorbidities. So starting ART early is very important. Secondly, the diagram I've shown here actually comes from the European AIDS Society guideline on HIV management. This is the table of contents page, obviously, and the right column that I've highlighted represents all the medical conditions not directly due to HIV, meaning the screening and management of diabetes, high blood pressure, chronic kidney diseases, et cetera. So you can see that the proportion of HIV and non-HIV or directly related to HIV actually is of equal or even more important in the management or long-term management of people with HIV. And thirdly, as I've illustrated with all these examples of geriatric syndromes, it's very important that we do monitor their intrinsic capacity or their functional ability to maintain their expected quality of life. And I'll elaborate on this a little further. To do what I've just summarized in the slide above, there are obviously some challenges. Currently in Hong Kong and globally, basically everyone's providing antiretroviral therapy once a patient is diagnosed. What is the greatest challenge for older people is that they are often diagnosed late. So if you compare the age distribution curves for people with HIV and those with AIDS on the lower diagram, it's quite obvious that people who are older, a higher proportion of them do present late with AIDS complications. So the prevention services, testing services for targeting older people, that's very often something that's left behind. So that's maybe a thought for us, for people here, the stakeholders here as well. I've talked about comorbidity screening and management. There's no one-size-fits-all best practice model, obviously. In different cultures, different settings, the best way to provide these services would differ and might even differ for person by person in the same community. And it would be important that when we are designing these service delivery model, we would have to provide a differentiated service needs to cater for the different needs of the population. And finally, the WHO actually had a healthcare model on aging. And it actually comprises both intrinsic capacity, which is shown on the diagram here, looking at the different components that would maintain a person's ability to do what they actually want to do. But also importantly, the external environment is also very important. And that would include all the services and the infrastructure in a society that would enable an older person to live the way they would like to in a particular society. So therefore, in terms of healthcare, of course, these are the things that we would like to maintain and also bear in mind when we design the components that are essential for our healthcare services for people with HIV. So with all that, I hope I didn't give you a too pessimistic picture of aging, which is basically inevitable for any of us here. But all these models, diseases or conditions that I've discussed, I think brings a very important issue is that aging well is possible. We can't prevent aging, but we can choose to age well. And this is also something that we can do for ourselves and also for our clients. So thank you very much, and I'm happy to answer questions.
Sorry that because Dr. Yip has an appointment, so she has to leave early. So if you have any questions regarding Dr. Yip presentation, you can email us and we'll get back to you through email. Yeah. Okay, so we have 5 minutes. Any questions regarding the 4 presentation and sharing, the 3 presentation and sharing? That's a question.
Just a quick question to, I believe it was Dr. To get the names correct, I'm sorry, about the commons. What is the thought process behind making this a referable service that you have to go through via an NGO? Isn't that increasing kind of the access barrier a little bit, or what is the thought process behind that?
Because the setting is that we want to really focus on the higher risk population, so there is a bit of screening may be required, like for the people to really have the high risk, like sexual partners and etc. That's why we try to make it more targeted to focus on a particular group. And the other thing is we gather a lot of NGOs, they are already in touch with these clients that has a certain increased risk of sexual transmitted infections or HIV. But then sometimes they may also have difficulty to get tested because they may not want to go to private, and sometimes the public service may be a bit long in terms of waiting. So that is sort of the idea is also to while they can have all the counseling and also the assessment going around in the community, the Commons can also provide a place that they can be tested safely and they can feel comfortable to come and get tested and try to be a more friendly area to patch up that sort of medical part that they needed in the very first place. But of course, this is something that we always will review, like maybe in times after, because it's a relatively new service. So that's why we have been saying it's a lot of times we need communication with the stakeholders on how can we make it more accessible to the clients, how we make it easier for different organizations as well. So this is all under regular discussion and reviews, and our plan is to always ask whether the stakeholders have comments. Then they can really feel free to feed it back to us, so we can think about it more to make it more accessible. Let's put it this way.
Hi, I've got a question for the speakers. People who have HIVs, I mean, a lot of people are aging. Do you think people with HIV, when they get old, they will more prone to problems or issues surrounding aging, or in a certain way, will the onset of these problems start earlier than normal people who get old?
Yeah, so I think it's quite certain that we do experience these age-related problems earlier in people with HIV than the general population. So in the earlier part of the talk, I'm trying to show some evidence showing the more rapid pace of aging in people with HIV. And even with treatment, that's obviously with improved outcomes, but it's not entirely going back to the pre-infection state. So it would be not unsurprising that people with HIV, they have these age-related health issues earlier, and also and that would also translate to the impairment in function as well. I think was not the reason I put in the last slide was that we often think that aging is a irreversible process, and although it might be true, but the rate of aging and also the things we can do to prevent more rapid aging actually still exists. So I think. For example, with early effective antiretroviral therapy, it has been shown that it can actually improve health outcomes. And also the reason why I do think that regular monitoring of all these parameters of aging would be important is that whenever we identify some early issues, we actually can introduce some interventions, for example, in terms of lifestyle modification, that actually might improve the age-related health outcomes as well. So another challenge that you actually bring up is that because people with HIV do encounter these issues earlier in their life, and they are actually not in the geriatric population as like what our geriatricians usually encounter. So most people geriatricians see are in their 80s or at least 70s. But when a person starts to encounter these geriatrics-related issues in their late 50s or early 60s, geriatricians might not be very comfortable taking care of these issues, or their health needs would be a bit different from people who are in their 70s or 80s. So this also poses a challenge to the healthcare system as to who are the best providers in terms of health delivery when we do see people with HIV together with these age-related problems.
Okay.
Yeah, I actually have a question for these speakers. A case that I have encountered in the private sector who was newly diagnosed HIV, and I wanted to refer them to Princess Margaret and the centers. But one of the concerns my patient had was, if they go to the government, will their details be available? That their employers, because they worry that their employers might find out that they're HIV positive, so they worry. They have all sorts of concerns about that. So is it something that they should be aware of when we refer them to these Department of Health centers?
This is a very common and very real life questions. A lot of times when they first come to see us, the first thing that we address to them is that every of your medical record is on a confidentiality protection thing. So it's only your medical team that is taking care of you have the right to really see your medical record. And in Hong Kong, we don't share with your employers. We don't like write letters like tell people that you have this condition. And even sometimes a lot of people still ask me if let's say I'm seeing HIV in the Department of Health, like is my medical condition, all my diagnosis, all my testing results, everything else directly transmit to every other medical units in Hong Kong, like private, in hospitals, and especially with a lot of government initiative going around on the healthcare sharing. So we spend a lot of time telling them the difference between each and every sort of platforms that we're using, what is the scope of sharing of the information, why we sometimes think it is good for them to have a bit of information sharing is to protect their health, but not to safeguard the safety of the medical advices and the medicines and the interventions that we're doing, but it's not trying to breach their confidentiality. So I think it's a lot of times it's about communication. It's about explaining to them. It's about telling them what is the difference between this and that, and trying to, as Dr. Goh has been telling a lot in his sharing, is to really get down into that deep core and the concern. And what we don't want to have the final result is that because of the fear and the misunderstanding about this, affecting them to go and seek care, to be linked to the care and to receive the drugs that they need, the treatment that they need. So the simple answer is that no, it's not shared to your employers, it's not shared out without your consent. So it's a lot of explanation that we're still trying to do, and we're trying to give them a space that is safe, and they feel it's okay to ask anything. So we will try to address these concerns to them.
Well, I think to supplement, of course, we are keeping everything confidential. But what that's quite inevitable is that the people in the healthcare system, so I mean the healthcare providers who are providing care for that particular patient within the system, they would be aware of the HIV status of that particular person. And very often patients are quite concerned about this. So, for example, they would get HIV care from the HIV clinic, but they would be seeing other doctors for other reasons. And I am very sad to say that it's not uncommon that patients do encounter a lot of stigma within the healthcare setting. And I think that's one of the reasons why they have concerns that other healthcare providers would be aware of their status once they are sort of registered in a public healthcare setting. And I think as healthcare providers ourselves and working in this field, we all have the sort of responsibility to promote these messages. You equals to you, promote what's the landscape we are on for HIV now, not like 30, 40 years ago. And in terms of training education of our healthcare professionals, for example, for us, providing medical education to our medical students and also the other nursing, allied health, is of paramount importance that they do receive this training very early on in their career.
Thank you so much. Actually, Dr. Lui is already giving us an introduction and preview of the next sections after the break, because I think it's really the structurally, systematically, whether we can create non-judgmental environment, inclusive environment, that's how we can, manage the root of the problem, that we all discuss. So thank you so much. Thank all the speakers. And we'll have a 5 minutes break. And then after that, we will start our section on the social health, and we'll also talk about stigma. Okay, thank you.
At Gilead, we have been committed to delivering person-centric advances in HIV research for more than 35 years. Our latest innovation spotlight will focus on the concept of drug resistance. Drug resistance can impact the selection of treatment regimens and is an important area of our long-term HIV treatment research. HIV drug resistance is caused by mutations in the genetic structure of HIV that may affect the ability of medicines to block the replication of the virus. All antiretroviral drugs, including those from newer drug classes, are at risk of becoming partially or fully inactive due to the emergence of drug-resistant virus. Today's treatment regimens are highly effective at lowering the amount of HIV in the body when taken as prescribed. However, the virus may be resistant to treatment for several reasons, including past treatment failure due to resistance development, challenges with medication adherence, or acquiring drug-resistant strains of virus. If HIV does begin to replicate once again, the virus may also gain the ability to evade certain medicines that were previously effective. This creates the potential for development of resistant strains of the virus that may be passed on to others who also may now have fewer effective treatment options available to them. Drug resistance is a key area of focus for our long-term HIV treatment research. Scientific discovery will have the most significant public health impact in minimizing the effect of HIV drug resistance on the global treatment landscape and get us one step closer toward the ultimate goal of ending the HIV epidemic for everyone, everywhere.
People often say, everything is fine. But then again, they also say things like, we're loving this. And, great idea, boss. Then there are those who reply, looks great. Or say, close enough. They tell themselves, I'm all right. I'm all right. Still all right. While others answer, so good. Some respond with, I can make it work. And every so often they say, that's nice. Then there are moments when people say, this will be okay, even when they think it won't be okay. So when people say everything is fine, is it?
At Gilead, we have been committed to delivering person-centric advances in HIV research for more than 35 years. Our latest innovation spotlight will focus on the concept of drug resistance. Drug resistance can impact the selection of treatment regimens and is an important area of our long-term HIV treatment research. HIV drug resistance is caused by mutations in the genetic structure of HIV that may affect the ability of medicines to block the replication of the virus. All antiretroviral drugs, including those from newer drug classes, are at risk of becoming partially or fully inactive due to the emergence of drug-resistant virus. Today's treatment regimens are highly effective at lowering the amount of HIV in the body when taken as prescribed. However, the virus may be resistant to treatment for several reasons, including past treatment failure due to resistance development, challenges with medication adherence, or acquiring drug-resistant strains of virus. If HIV does begin to replicate once again, the virus may also gain the ability to evade certain medicines that were previously effective. This creates the potential for development of resistant strains of the virus that may be passed on to others who also may now have fewer effective treatment options available to them. Drug resistance is a key area of focus for our long-term HIV treatment research. Scientific discovery will have the most significant public health impact in minimizing the effect of HIV drug resistance on the global treatment landscape and get us one step closer toward the ultimate goal of ending the HIV epidemic for everyone, everywhere.
People often say, everything is fine. But then again, they also say things like, we're loving this. And, great idea, boss. Then there are those who reply, looks great. Or say, close enough. They tell themselves, I'm all right. I'm all right. Still all right. While others answer, so good. Some respond with, I can make it work. And every so often they say, that's nice. Then there are moments when people say, this will be okay, even when they think it won't be okay. So when people say everything is fine, is it?
At Gilead, we have been committed to delivering person-centric advances in HIV research for more than 35 years. Our latest innovation spotlight will focus on the concept of drug resistance. Drug resistance can impact the selection of treatment regimens and is an important area of our long-term HIV treatment research. HIV drug resistance is caused by mutations in the genetic structure of HIV that may affect the ability of medicines to block the replication of the virus. All antiretroviral drugs, including those from newer drug classes, are at risk of becoming partially or fully inactive due to the emergence of drug-resistant virus. Today's treatment regimens are highly effective at lowering the amount of HIV in the body when taken as prescribed. However, the virus may be resistant to treatment for several reasons, including past treatment failure due to resistance development, challenges with medication adherence, or acquiring drug-resistant strains of virus. If HIV does begin to replicate once again, the virus may also gain the ability to evade certain medicines that were previously effective. This creates the potential for development of resistant strains of the virus that may be passed on to others who also may now have fewer effective treatment options available to them. Drug resistance is a key area of focus for our long-term HIV treatment research. Scientific discovery will have the most significant public health impact in minimizing the effect of HIV drug resistance on the global treatment landscape and get us one step closer toward the ultimate goal of ending the HIV epidemic for everyone, everywhere.
People often say, everything is fine. But then again, they also say things like, we're loving this. And, great idea, boss. Then there are those who reply, looks great. Or say, close enough. They tell themselves, I'm all right, I'm all right. Still all right. While others answer, so good. Some respond with, I can make it work. And every so often they say, that's nice. Then there are moments when people say, this will be okay, even when they think it won't be okay. So when people say everything is fine, is it?
At Gilead, we have been committed to delivering person-centric advances in HIV research for more than 35 years. Our latest innovation spotlight will focus on the concept of drug resistance. Drug resistance can impact the selection of treatment regimens and is an important area of our long-term HIV treatment research. HIV drug resistance is caused by mutations in the genetic structure of HIV that may affect the ability of medicines to block the replication of the virus. All antiretroviral drugs, including those from newer drug classes, are at risk of becoming partially or fully inactive due to the emergence of drug-resistant virus. Today's treatment regimens are highly effective at lowering the amount of HIV in the body when taken as prescribed. However, the virus may be resistant to treatment for several reasons, including past treatment failure due to resistance development, challenges with medication adherence, or acquiring drug-resistant strains of virus. If HIV does begin to replicate once again, the virus may also gain the ability to evade certain medicines that were previously effective. This creates the potential for development of resistant strains of the virus that may be passed on to others who also may now have fewer effective treatment options available to them. Drug resistance is a key area of focus for our long-term HIV treatment research. Scientific discovery will have the most significant public health impact in minimizing the effect of HIV drug resistance on the global treatment landscape and get us one step closer toward the ultimate goal of ending the HIV epidemic for everyone, everywhere.
We are going to start our last section on social health. So please be seated. So you'll still have time, to build connections and build your social health after the conference. Have a seat. OK， 傾到好興奮，我見到呢三位朋友係 OK。Thank you so much. So we're going to start our last section of today's conference. It's about social health. When we talk about social health, it's about connections, it's about relationship, it's also about respect for others. So the theme of this section is cultivating connections, enhancing social health for sexual well-being. Social health is a key protective factor that fosters resilience to HIV/AIDS and sexual health problems. So the topic today is that we will engage a panel of experts to explore the strategy and approaches on how to use technology, how to use different models, and also how to structurally address the issues of stigma to promote sexual health in a bigger picture. So I will introduce our first speaker, Professor Stefano of Benini. I've been practicing many times, so sorry. I have some challenge pronouncing his name for this panel. So his topic will be on the multiple phase of HIV/AIDS in Hong Kong and beyond, structural stigma in health and communication. Professor Stefano is a professor of health communication and director of International Research Center for the Advancement of Health Communication in the Hong Kong Polytechnic University. He researches health and communication in socio-cultural contexts and focuses on how people perceive and talk about health conditions and those who live with them, especially in relation to stigma. He's interested in application of social psychological theory, qualitative approaches, and innovative quantitative analytic techniques, and address transnational research questions with applied goals. So without further ado, I would like to invite Professor Stefano on stage. You want to have the mic? Or?
Yeah, I think there's a mic.
Okay, good.
Can you take a couple of pics on the
Yes,
phone?
sure.
Thank you. Thank you very much. Is this the clicker? Thank you. Stefano Occupinti. That's I don't want to stigmatize you for saying the name. But yeah, thank you, Nita, and thank you all for staying for this final session. And of course, we've got to talk after the final session too. So I'll try not to take up too much of your time, and I certainly will try not to be bogged down in slides with lots of words in them. You've been hearing about stigma, and actually stigma has been mentioned in every single talk that I've been able to see so far since lunch. So I won't belabor that part. We know that stigma is a property that accrues to a group, not people. The earliest discussions of stigma in social science, it's been discussed for thousands of years, but in social science, the earliest discussions of stigma often spoke about health, and health conditions were some of the key stigmatized marks that were discussed. We know that stigma has key psychological and physical outcomes in terms of health. In particular, for example, stigma often prevents people from seeking primary care and prevents people from seeking health care until often it's quite a bit later. In the field of cancer, which is where I've done a lot of my previous work, in stigmatized cancers, people are often diagnosed at later and more complex and difficult stages, for example. Now, there's been a lot of work done on mental health stigma, rightly, because it is a great big problem in that area. And indeed, in Hong Kong, there's also been quite a lot of really good work done in mental health stigma. There's been less work done generally, and still less work, I think, done in Asia, with Asian populations, on general health stigma, which is what I'm going to be talking to you about this afternoon, and in particular with respect to HIV and people living with HIV. Stigma, I'll just briefly note on the right-hand side, is Erving Goffman's original work from the early 1960s. He talks about signs that refer to the moral status of the bearer. Stigma is about morality, and often we forget that. That is, the stigma is a thing that people use to make judgments about morality, that involve morality. And it helps groups to try to stay away from the blemished person, to keep them away. These are themes that are going to come through the data that I'm going to show you. So we know that stigma accrues to the individual, and of course it often occurs in interpersonal contexts. However, of course, stigma is really about a group. You don't stigmatize a person, you stigmatize the group to which that person belongs. And that groups are set within a societal and a cultural context. We can't avoid that, although often we tend to try to apply one single model of stigma to all the different sorts. And this can be sometimes a little bit of a hindrance. One of the key explanations for stigma, though, and this follows on from the work of Erving Goffman in the 1960s, is by Link and Phelan. This is very widely cited and discussed. And the three key points of stigma, according to Link and Phelan, are first of all that we have to have groups that can be labelled, that in some way stand out, either visually or cognitively. Secondly, these are connected to chronic beliefs about these groups, and often these are negative, because we're talking about stigma. It's not a pleasant thing, and we've heard about the stigma which is experienced and felt by people living with HIV this afternoon and indeed throughout the day. Thirdly, the crucial ingredient is about social power. Stigma is not about about anything positive. Stigmatized groups in some way start to lack social power, and the mainstream is able to kind of use the greater social power that they command, and we can see this economically, you know, we can see this quantitatively as well as qualitatively, is able to use the greater social power to limit the opportunities and to in various ways reject the advancement of the stigmatized group. And so the avoidance and the status loss that we see in stigma are essentially a function of these three key features. And we know that these are all cultural processes. I'm not going to spend very long on this at all. This is a blowing of the trumpet in some ways, given that we've sort of talked about all of these things. Some work that our group has done over the years, more recently. And I guess to provide some context for the data that I'm just about to show you, some colleagues and I did a large-scale study with US adults, and we sort of found that, in fact, there were some three key separate functions of stigma, that all stigmas were not the same, and that some stigmas were about shielding us from immoral others, sort of guarding our morality. Some stigmas were about keeping us away from people who interpersonally, or groups who would interpersonally bring us down, who would lower our social status. And there was a third sort of more chronic type of stigmatization that I won't talk about here. But in particular, these different functions of stigma were associated with different emotional responses to those stigmatized groups, and that is going to be of relevance to the data that I'm going to talk about. The other thing that I just would bring up is a study I did a few years ago now with lung cancer patients and caregivers in Australia. This was a qualitative study as opposed to the quantitative. And incidentally, lung cancer is another health condition where, in fact, people with lung cancer feel that they're seen, and that they feel like they are, and they feel that they're seen as less worthy than sufferers of other cancers. And they often compare themselves to, for example, to people with breast cancer as being less positive, and they also report stigmatization and negative responses from healthcare providers. So there are certainly parallels here. One of the things I found that in lung cancer stigma in particular, there was a very strong sense of moralization. It wasn't just about the personal responsibility of someone choosing to smoke and then winding up with lung cancer. And of course, we know that that's not the whole story, but this is the stigmatizing thought. But it was often about moral judgments. And indeed, that the stigmatizing interpretations were widely shared. And this is another thing that we should be thinking about. We're talking again about societally shared beliefs, not just beliefs amongst certain individuals, but widely shared. In fact, I talked to patients and carers who were smokers and non-smokers, because up to 30% of people with lung cancer, in fact, are not smokers. All sorts of reasons for that. They all understood the same stigmatizing beliefs that were promulgated. It's impossible to tell them apart on that basis. Stigma is a socially shared phenomenon. So this brings us to this notion of structural stigma. And so I guess the chief proponent of structural stigma in the last few years has been Mark Hatzenbuehler in the US. And there are two kind of aspects, or two major aspects to structural stigma. And at a policy level, he sort of notes policy as being the first level. And this is what many people, especially those trained in a more sociological tradition, would see as being structural stigma. It's about social structure. The structures of society are lined up to exclude or somehow hinder the progress of stigmatized groups. And so we know that this can happen in terms of access to treatment. We've heard about people's access to particular HIV treatments, for example. Recognition of relationships and all sorts of other things that occur in society that in some way are prevented or are denied to members of a stigmatized group. The other aspect of structural stigma, and again we'll be talking about this in the data, is this idea that it represents a sort of a synthesized general negativity of belief in society. I've called it there a summation of the negative beliefs about stigmatized groups. And so we've got some data on that too. So we're sort of looking then at structural stigma more broadly about people with HIV, as it happens in Hong Kong. Now, this is data from a much larger cross-cultural mixed methods study, and that's got about 1,500 people in it. I'm taking a small, about 220 portion of that, which are comparing respondents from Australia and respondents from Hong Kong, representative general public samples tested online with the aid of essentially a data gathering company. I won't go on about this sort of boring part, and I'm specifically comparing Australia and Hong Kong in terms of the respondents, and I'll show you why in just a second. We asked people questions about moralisation, the extent to which a particular health condition was seen as being linked to moral causes. We asked them about public stigma, especially in terms of emotions experienced in response to the target group. We asked them beliefs about social structure, and also about the sense of perceived prevalence and personal risk for the health conditions, because we know that sometimes conditions that are seen as being linked to more personal risk are potentially more stigmatised. And finally, we touched in on the idea of family blame, because families also bear the brunt of a lot of stigma, especially when it comes to health. We know that there's a big aspect of family stigma in mental health, and it was particularly relevant to a range of different health conditions. Now, we asked all of these questions of everyone. We asked them about different health conditions. I'm showing you the people who were specifically asked these questions about HIV. And we also asked them their perceptions of an imaginary person living with HIV. We asked them the questions that are generally used in social psychological research to gauge what we call person perception. So basically, I'm going to be showing you the data now. So just before this, I'm talking about the quantitative data, but prior to this, we did a qualitative component. And as it happens, we asked people about stigmatised conditions in a fairly indirect way to not prime them. But spontaneously, we had about 40% of respondents from HK nominated HIV/AIDS as being a stigmatisable condition, a condition that drew stigma within their society. In Australia, there was no, these are the top 8, there was sort of, if anything, negligible mention of HIV/AIDS. Australians certainly stigmatise things, there's no doubt about that, but by comparison, it's a much lower level of stigma associated with HIV/AIDS, not absent, but lower. So it provides a sort of a natural kind of comparison point. And also, a lot of the work in Australia is based on the kind of dominant Western conceptions of stigma, which I suggest may not be completely applicable to the East Asian and the Hong Kong setting in particular. In each of these bars, the blue bar is Hong Kong, and the kind of pinky bar is Australia. So we can see that indeed people in Hong Kong believe that most other people in Hong Kong see HIV as a condition that's linked with more moral causes than other conditions, and they believe this to a greater extent than Australians. So we've established that sense of moralisation. There's other data that comes to bear on that. Oh, I beg your pardon. Now we're going to talk about public stigma. So this is, to what extent do you think people in your culture feel the following emotions about members about people with the particular health condition, which in this case is, of course, HIV. So people in Hong Kong have a higher belief that the people would feel threatened, afraid, and less happy. Ooh, sorry for the shouting there. Interestingly, no difference in pity. So they don't believe that people in Hong Kong would have less pity, but they are higher in threat, afraid, and happiness. Not surprisingly, given the moral basis of stigma, and this is, by the way, HIV is not the only health condition that has a clearly moral aspect sort of to it in terms of the stigma. This is actually a very broad phenomenon. It's not in any way linked merely to HIV. Disgust is the emotion that's linked with morality. So people, they were higher in disgust, but not higher in anger. And anger is another emotion that's linked to morality. They were more frustrated and embarrassed, which kind of link in many ways. We asked then about social structure. Now, interestingly, when we asked them about the likelihood of gaining employment for a person living with HIV, about public education about HIV, about media reports about HIV, there was no difference between the Hong Kong and the Australian respondents. They didn't their beliefs about these potential sort of difficulties here were not different. However, where they were different was in, and this is, by the way, this is difficulties in finding an intimate relationship. So in Hong Kong, people perceive these to be, perceive there to be more difficulties than in Australia. And also in finding treatment for HIV. And we've heard about the ways in which we're trying to make treatment more accessible, in fact, this very afternoon. Again, Hong Kong saw more difficulties with these aspects of social structure. Now, then we looked at, as I said, at the perceived epidemiology. Maybe people in Hong Kong are sort of showing this higher level of public stigma because they're more, you know, they seem as they're more threatened. Maybe they think it's more likely that they'll come to deal with it. But in fact, no, there's no difference there at all in the perceived prevalence, nor is there a difference in personal risk. In fact, personal risk is quite low. So what we're seeing does not seem to be associated with some idea about how widespread and about how personally risky HIV is in either Australia or Hong Kong. Interestingly, HIV is seen as being more controllable in Australia than in Hong Kong. The important thing about this is that very robust finding in most Western samples is that the more controllable a health condition is, the more it's actually stigmatized. The more that it's out of your control, the less it's stigmatized. And it's believed because it's about personal responsibility. If it's under your control, it's up to you to be able to not in some way get the condition. People talk about this in terms of lung cancer. You could have chosen not to smoke, therefore it's under your control. Interestingly here, and this fits with other parts of our data and other parts of other people's data, I think it's a fairly robust finding. There are lower perceptions of controllability in Hong Kong, not higher, and that's actually significant. Then we move on to then family blame. And so this is, again, we ask these of all the health conditions. To what extent is the family responsible? Members of the family of the person responsible for them getting this health condition? And this is quite interesting. There was clearly an effect here. So in terms of the family's bad luck, so again, the blue bar is Hong Kong. In terms of parenting, which is an interesting one from my point of view, genes, the effect is there. It's a bit smaller, and then also maternal pregnancy behaviour. But of course, in some ways, not surprisingly, given what we also know about the stigma that accrues to people living with HIV, beliefs about sin and immorality were much higher in Hong Kong than Australia. The important thing about this is, of course, we're talking about the sin and immorality of the family, not of the person with HIV. So there seems to be clearly a connection here to family stigma. Now, finally, this is the last sort of section that I'm going to show you. We asked them to imagine a person living with HIV. We've also got data on the age and the gender and other aspects of this person that they imagine. There just isn't time to share that with you. We got them to imagine the person and then to rate the person on a widely used series of social psychological scales that examine the different dimensions of person perception. And so what we found is that in Hong Kong, these are small but reliable differences. There's a tendency to see the person as being less moral than in Australia. There's no difference in how sociable the person is. And there is a difference in terms of the competence. So the morality and the competence are the two key dimensions of person perception generally. So the person is seen as being less competent, but there's no difference. We were also interested to see whether often we see in social media and other sorts of areas this idea that people who are living with a challenging illness somehow develop a sort of magical toughness and strength and endurance, and we sort of call that grit. But in fact, people don't perceive people living with HIV as having any more or less grit, whether they're in Australia or in Hong Kong. But there are differences in terms of the morality and the competence. So, first of all, I guess I just want to emphasise that these are differences between Hong Kong and Australia that, in terms of HIV, that I thought were particularly relevant to what we're talking about this afternoon. There are, as I said before, there are plenty of things where Australia stigmatises much more than other countries, such as, for example, obesity. But we've seen the sort of the distinction, I guess, between the Hong Kong and Australian data in these particular aspects. And what I think is of interest here is not so much we know that the stigma is there, and the stigma is there in different places, in different ways. It's about why is the stigma happening? What is actually driving the stigma, and what are the facets and particular functions of stigma here? What I think, I'll get back to the first point in just a second. What I think we can see here is that the nature of public stigma in Hong Kong really seems to be much more strongly avoidant than approaching. That is, the emotions are those of avoidance, disgust, and frustration and contempt. They're not the emotions of approach, such as anger and pity. So the real issue in some ways appears to be that there's a belief that in Hong Kong we're sort of trying to keep people away like that. And in that sense, I think we understand that there are beliefs, there are negative beliefs that involve the family and other aspects of the person's life. And so I think in terms of future research, first of all, we want to understand that really much more now the interconnections and the essentially the networks of these different factors as they occur in Hong Kong. Secondly, one of the things I think we need to do now in pressing ahead with a kind of a jointly quantitative and qualitative approach is to make use of the language people are using. The language as a way to quantitatively assess, and we're doing this now. I'm kind of like surrounded by linguists where I work, making use of people's language as a way to quantitatively assess both the level and the nature of the stigma that they express. I'll only say a couple of things in terms of implications for healthcare. We've heard lots of them. I found myself nodding furiously as people were talking throughout the afternoon. I think a key thing is I'd sort of focus on the second point in terms of focusing on encouraging adaptive beliefs around the place of people living with HIV in the shared social space. I think that's the way of really directly contrasting against the avoidant and rejecting as aspects of stigma that we understand are probably still out there. So I'll be glad to answer any questions during the Q&A, and if anyone has any further interest, do feel free to get in contact in the usual ways. Thank you.
Thank you very much. So now we are going to have our second speaker, Professor Johnson Wang, to share with us on the topic, development and evaluation of a chatbot providing real-time counseling support HIV self-testing for men who have sex with men. So I will give you some background about Professor Wang because we've been working together, like in some of the project and AIDS concern. And Professor Wang has been appointed as an assistant professor in the JC School of Public Health and Primary Care since 2020. He is a member of the executive committee of the Center for Health Behavior Research, CUHK, and the associate director of Community Research Program on AIDS. So without further ado, I will introduce Professor Wang to the stage and share with us on the topic of using the chatbot, for the HIV self-test. Okay, thank you.
Thank you. Okay. Thank you, Anita, for the introduction, and also thanks everyone for giving me a chance to share with you our project. So first of all, I would like to thank all my research team members and the support from AIDS Concern, and also the funding support from the AIDS Trust Fund. Okay, so first of all, I will quickly go through the background of our study. So why do we come up with such an idea? So we all know about the importance of HIV self-testing. So it was considered as one important strategy to achieve the 395 targets established by the UN AIDS. And But sometimes there are concerns related to the HIV self-testing. So one of them is lack of the counseling. So although very convenient, so some HIV self-testing users, they may skip the pre-test and or post-test counseling. So that will result in some issues. For example, like the incorrect procedures that will lead to some invalid results. So if you have tried HIV self-testing before, when you open up the package, then you read the instruction, and the form was very small, and sometimes the instruction was not very clear. And also, another bigger issue is that the inadequate support for the users, especially when you are tested to be HIV positive. So imagine, so when you're doing a HIV self-testing in the midnight at home and you turn out to be positive, so what should we do? So what should we call? Okay, so it was at the midnight and nobody can help. So, and also these issues, so they lead to the problems of the linkage to care. So according to previous literature, so for the HIV self-testing, so the linkage to care was lower than the standard of care facility-based HIV testing and counseling service. And also there are studies show that the self-testers, they consistently wish that the pre-test and post-test counseling for HIV self-testing to be available. So we are now clear that we need to provide some kind of counseling support for the users, but how? And so there are two major ways for providing the counseling support. So one, we call it active counseling. So that means we proactively provide counseling to all the users, so unless they refuse that kind of service. And in contrast, another type, we call it passive. So we just wait there, okay, wait for the HIV testers to come out to find us, okay? So we do not provide any active counseling to users, but they can report the result via some web-based platforms, and they can obtain some optional counseling. And my PhD, Edwin, he did a meta-analysis about the type of counseling support among the MSM HIV testing users and the link to care. And we find that, so in fact, so nowadays, the majority of the HIV self-testing service, they are providing some kind of active counseling support. So, so as you can see the number, so 50 studies providing active support as compared to only 5 studies provide some passive support. So when you're looking at the link to care, so among between these two types, we can find that, so if we provide active counseling support, we can have significant higher linkage to care, such like the linkage to laboratory confirmation, ART initiation, and also referral to physicians. So, so now we're clear that we need to provide counseling support and we need to provide active counseling support. But how can we provide active counseling support? So in our previous project, so we develop and implement a home-based HIV self-testing service. So we call this service we called it. It has a real-time counseling support. So via some live chat application. So So we mail out a free HIV self-testing kit by mail, or they can also pick up through some pickup service. Then upon the appointments and experienced HIV self-testing administrator will provide online real-time instruction and the pre-test and the post-test counseling via some live chat application, such as WhatsApp, Line, or Skype. So it has some strengths. So we evaluate this new service through using the randomized control trial, and we find that it can significantly increase the HIV testing uptake. And also, it can ensure very good linkage to care. And also, it can reduce the sexual risk behaviors. And this, we call it HIV OIC, STOIC. It was also listed as one of the evidence-based structural intervention by the US CDCs. But during the implementation, we find out there were some issues. So so usually, as I mentioned, so the people like to do HIV self-testing at home during midnight or even during the holidays. So it's not always hour, okay? So, so it created a very big challenge for the HIV self-testing administrators. So nobody can work 24 hours per day, okay? So especially for our NGOs, okay? And each section, it will take about 40 to 60 minutes to implement. So, it was quite resource demanding. So that's why it is very difficult to implement at larger scales. And how we can overcome these implementation issues. So, and the chatbot actually come into our site. So, so I think everyone know what is chatbot. So it is a computerized program. So it was act to replicate the human interaction. It can through the text, speech, or even the visual forms of communication. So in the recent days, so the use of large language model and the machine learning, it largely increased the accuracy of the human-machine interactions. So there are a lot of advantages of using chatbot because it can offer some personalized, engaging, and on-demand health promotion. And it can also proactively interact with the users, so which can improve some compliance. And more importantly, it's fully automatic. So if it is in place, so it requires fewer resources to maintain or implement. So we have the idea, so we are trying to use the chatbots to deliver this kind of online real-time instruction and counseling support to support the HIV self-testing users. So our project, we do have two phases. So the first phase is to the development of the chatbots, and the second phase is the evaluation of the chatbot. So in the second phase, we compare our HIV self-testing chatbot versus our human service, the HIV self-testing OIC, and to see which one is better. So there are some specific objectives for the second phase. So the primary objective is to establish whether the HIV self-testing chatbot will produce some similar effects as compared to the HIV-ST-OIC in increasing the HIV self-testing uptake, as well as the proportion of HIV self-testing users receiving the counseling along with the testing within a 6 months follow-up period. And our secondary objective is to test the between-group difference in the prevalence of sexual risk behavior, like the condomless anal intercourse, the multiple sex partnership around the self-testing users, as well as the uptake of other HIV testing other than the HIV self-testing during the follow-up period. So then I will talk about the methods. So this is how we develop our chatbots. So we use a community participatory approach to develop the chatbots. So we interview our end users, so the MSMs, as well as the HIV testing administrators. So we crowdsource a lot of common concerns and frequently asked questions related to HIV self-testing and HIV testing. And we also try to understand the potential users' preference and their expectation about the chatbot. So by taking this into account, so we use the WhatsApp to implement the chatbot. So why we chose WhatsApp? Because I think it's the most popular instant messaging apps in Hong Kong. It's almost 90% of the Hong Kong people are using WhatsApp. So the technical barrier will be lower. So this is the architecture of our chatbots. So the chatbot has two parts. So one is the chatbot system, and the other is an administrative system. So when a user sends a message to the WhatsApp, and the WhatsApp app will forward the message to our chatbot system. Then the chatbot system will process the message based on our predetermined rules and send a response back to the WhatsApp server. And the WhatsApp server will then show the message to the users. So the whole process will last less than a second. So, and the users will not feel any sluggish. Okay. And when the chatbot was in place, so we conduct a pilot testing. So we invite 30 MSM to use the chatbots, and their conversation with the chatbot was retrieved by the research team, and they will review and will improve the performance of the chatbot. So here's the workflow of our HIV self-testing chatbot. So basically, we are simulating standard of care pre-test and post-test counseling. So the first part for the pre-test counseling, first of all, is a risk assessment. So the chatbot will ask some standard questions to assess users' HIV risk, and the participant can answer the question in a very flexible manner. So they can either select the response by clicking a button on the screen, or they can key in their answers, or they can use voice message. So it's quite flexible. And then the chatbot will interpret their response and then define their risk level. And the second part, the chatbot will provide some health education advice tailored to their risk level. And first of all, it will inform the users about their risk level and explain the rationale. And for those who are at high risk, the chatbot will prepare them for the potential positive results. For example, by explaining how effective the HIV treatment it is and what they need to do if they obtain a positive result, and also our support for the HIV, for those who are tested to be HIV positive. And for those who are without high risk, the advice on maintaining safe sex practice are provided. And then you will obtain the consent to perform the HIV self-testing. So the chatbot will ask whether they are ready for it, and the users at this moment they can raise their concerns or questions. So they can they can either select their question using. We have a list of FAQs. Okay, so it was created based on our previous work. So the most frequently asked questions. So they can select one or more questions related to HIV self-testing or HIV testing. If their questions are not in the list, so they can enter the questions in the chatbot, and the chatbot will retrieve the keywords and to get the response from our QA database and send the response to the users. So, and then with the consent, the chatbot will play a pre-recorded online demonstration video showing the procedures of using HIV self-testing kit. So the user can either watch the demonstration for the oral fluid kit or the blood-based kit, so it was based on their preference. And then after they have the testing results, so we ask the chatbot will ask all the users to report their testing result. So they will need to answer questions, multiple choice questions, and the chatbot will show the example of the positive, negative, and also the invalid results to help the users to interpret their results. And also, the chatbot will ask the users to take a photo of their testing result and upload it to a secure web page. And the web page will be an analysis to confirm their testing result. And then, based on their testing result, the chatbot will provide the post-test counseling. So for those with negative results, the chatbot will explain the users now is not infected unless the test was taken within the window period, and remind them that the second screening is required after the window period. And also, they will remind them about the risk of HIV infection and provide some tips or advice about their safe sex practice and emphasize the need of regular HIV testing. And for those with HIV positive result, so the chatbot will automatically notify a designated supporting staff from the collaborative NGOs, and which will follow up with the users as soon as possible. So, and at the same time, the chatbot will explain, so this is a preliminary positive result, so they need to take a confirmatory HIV testing at the Department of Health. And also, staff from the NGOs is concerned that is already notified by the system and will follow them as soon as possible. And also, it will emphasize again about the effectiveness of the HIV treatment, and also we will provide the hotline number of some 24-hour emotional support, and also the hotline of our NGOs. And our project staff can accompany them to visit the NGOs or Department of Health if needed, so to ensure sufficient support was given. And also, we consider, so because now the HIV self-testing is quite popular, some of the MSM, they already have some rich experience of using the HIV self-testing. So they may not need comprehensive instruction and counseling. So they can feel free to choose 2 different service models. So the first one, mainly for the first-time users, we call it comprehensive counseling. So it is a standard of care pre-test counseling and the report of interpretation of a result and the post-test counseling. And for those who already have the experience, though, they can choose the simplified counseling. So they can skip the pre-test counseling, they just directly report their result, and the chatbot will interpret their result and provide the standard of care post-test counseling. And all of the users, they are strongly recommended to report their testing result. And so here, this slide shows the participant of this phase 2, which is a non-inferiority randomized control trial used to evaluate the HIV self-testing chatbot. So we mainly recruit the MSM, age 18 years or above, and they have access to WhatsApp and no intention to leave Hong Kong for 1 month consecutively within the next 6 months. And those who were already diagnosed as HIV positive were excluded. And this was the flow chart. So we approached 620 MSMs through multiple channels, and 531 agreed to participate in our studies, and they were randomized into the chatbot group and also the HIV-ST-OIC group. And in the chatbot group, so they will watch an online video promoting the HIV testing in general as well as the chatbot, and then they will be connected with the chatbot and then implement the service. And for those in the HIV-ST-OIC group, so they will watch a similar video promoting HIV testing in general as well as the human service, and then they will make appointment with the HIV testing administrators and then implement the service. And all participants will follow up 6 months afterwards. So our primary outcome is the self-reported uptake of any HIV self-testing and during the follow-up period, and also the proportion of the HIV self-testing users who have received counseling support along with the self-testing during the follow-up period. So these outcomes were validated. We try to validate the outcome because the chatbot will document the number of the HIV self-testing chatbot use, and the HIV testing administrator will record the number of the human service that was performed. And the secondary outcome include the condomless anal intercourse and the multiple sex partnership among the HIV self-testing users, and also the uptake of other type of HIV testing among all participants during the follow-up period. And let's look at the result of our studies. So majority of our participants were young, currently single, highly educated, fully employed, and identify them as gay. And the sexual risk behavior in the past months was comparable to the PRISM. So it's about over 50% of them report condomless intercourse and anal intercourse and multiple sex partnerships. And less than half of them use HIV testing in the past 6 months. And at month 6, so we can find 194 participants in the chatbot group use any type of HIV self-testing, so which is similar to the HIV-ST-OIC group, which is 74%. So when we look at the type of HIV self-testing taken by the participants, so majority of the HIV-ST users, they use the service provided by this project, so either the HIV self-testing chatbot or the HIV-ST-OIC. And about 5% of them also obtain the HIV self-testing from other sources. And during the follow-up periods, it's about 16% in the chatbot group and 90% in the OIC group. They take up other type of testing. So if we count all type of testing, so the uptake rate is about 77% in the chatbot group and So, and similar in the OIC group. So our hypothesis of the inferiority was proven, so which means the chatbot is non-inferiority to the OIC, the human service, in increasing the uptake of HIV testing. So we also conduct some subgroup analysis, and we find that there were similar trends in the HIV self-testing uptake among those with and without sexual risk behavior at baseline, and those with and without HIV testing in the past 6 months at the baseline. It's quite consistent across different subgroups. And interestingly, when we look at the proportion of HIV self-testing users receive counseling support, we find that significantly higher proportion of HIV self-testing users in the chatbot group receive any type of counseling. So it's over 90% of those in the chatbot group receive any type of counseling, so which is 30% higher than those in the human service group. So the OIC group is only 61%. So the proportion of using simplified counseling, which means the post-test counseling alone, is not, we did not find significant difference between groups, but the difference occur in the comprehensive counseling. So with about 35% of the users in the chatbot group, they use the comprehensive counseling support. So, and only 5% in the OIC group use that kind of comprehensive support. And it is encouraged to find that, so 100% of the HIV self-testing users report their HIV testing results to us. And when we look at the trend and in the sexual risk behaviors, so at baseline, so there was no between group difference in the sexual risk behaviors, but at month 6, the chatbot group has the prevalence of condom-less anal intercourse was significantly lower than the HIV self-testing user in the OIC group. And when we compare the within group difference as compared to the baseline, so both groups have significant reduction in the sexual risk behaviors. Okay, so we do find 2 HIV positive cases using the HIV self-testing chatbot. So, so for the first case, the users self-reported having a positive HIV self-testing result. And he also uploaded a photo, but the photo after analysis was in fact a negative result. But no matter, so either option will trigger our following up actions. So the HIV self-testing chatbot so immediately notify our project staff and provide the relevant information. And the project staff contact the users in the next morning because he did the HIV self-testing at midnight. Okay, so our project staff contact him in the next morning. And we arrange a confirmatory testing at his concern, and luckily he was confirmed to be HIV negative. And for the second case, the user self-reported having a positive result and also upload a photo with a positive result. And the chatbot will use and immediately notify the project staff, provide the supporting information, and we contact the users and arrange a confirmatory testing. But he was also confirmed to be HIV negative. So it may be the issues related to the oral food HIV self-testing kit. Okay. So as a conclusion, so we find that our chatbot is quite feasible and highly acceptable to deliver some real-time instruction and counseling support for the HIV self-testing users. And the randomized control trial proved that the chatbot was non-inferiority to the human service in improving the HIV self-testing uptake among men who have sex with men. And interestingly, we find that more HIV self-testing users in the chatbot group receive counseling along with the HIV testing, especially for the comprehensive counseling support. And the chatbot can ensure good linkage to care among the users. And both options, either the chatbot or the human service, are able to reduce sexual risk behaviors among the users. Okay, so this is the end of my presentation. I'm wondering whether I still have 1 or 2 minutes. Okay. So okay, okay, sure. Okay. So, thank you very much.
Thank you. you. I know Professor Wang got a video, want to show to you how the process work with the checkbox. Because I'm so sorry that because of the time. So maybe afterwards, if you're interested to get to know more about the project, please really reach out to Professor Wang and his research team. Okay, so we have the next speaker, Professor Edmund Choi, and his topic is on the perceptions and experience of sexual violence among Chinese men who have sex with men in Hong Kong. So we talk about social health, social well-being. So it's also involved. We talk about relationship. We talk about consent, etc. This type of topic. So I think this presentation will be going to echo some of these themes. So Professor Choi is a registered nurse and assistant professor at the School of Nursing, University of Hong Kong. His research focuses on sexual health with an emphasis on sexual minorities, adolescents, and young adults. He examines topical sexual health issues using randomized controlled trials, epidemiological surveys, and qualitative approaches. So without further ado, I will invite Professor Choi come to the stage and share with us his research.
Okay. Thank you. Okay, thank you. So in the interest of time, I will try to keep my presentation concise, and short. But first and foremost, I really appreciate your invitation. It's really my honor to be here today to speak with all of you and share two of my research projects in this topic. So today, I would like to talk about a very important issue in our society and community. So it is sexual violence. So broadly speaking, sexual violence include any sex act committed without the informed or voluntary consent of individual. So it is very important to understand that consent must be informed and indeed ongoing. So the concept of ongoing consent underscores the fact that the consent can be withdrawn at any time, actually. So an individual has the right to change their mind at any point, whether before or during sexual encounters. And also, consent should be specific. Agreement to one act doesn't imply consent to another. For example, agreeing to kiss doesn't equate to consenting to further sexual intimacy. So similarly, consenting to have one photo taken does not automatically mean agreeing to the dissemination of those photos. So there are different types of sexual violence, including attempt of completed rape, sexual coercion, compelling someone to engage in sexual activities against their own will through pleasure, manipulation, or threat, and unwanted sexual contact, any non-consensual interaction of a sexual nature, whether online or physical. And we also confront the act of stealthing, the intentional removal of a condom during intercourse without the partner's consent or agreement. And we must not overlook image-based sexual violence, which is an emerging issue in our community. So based on international study, actually there are a great disparity of sexual violence when we compare MSM with the heterosexual counterparts. It has been found that MSM are 6 times more likely to experience sexual violence in any form compared with heterosexual populations. And turning our attention to the disturbing prevalence of image-based sexual violence, another study, actually it is the data from Australia. So it is found that approximately 30% of MSMs have experienced image-based sexual violence. So this data is not just a number, actually, and provides solid evidence that there is a need to demand our immediate attention and action to tackle this emerging issue in our society. So because actually, of course, sexual violence or image-based sexual violence are not a very new topic in academic. But however, it's true that the study is really understudied in Chinese population. So we can't just utilize the Western population findings to apply to our Hong Kong setting because the cultural difference, the legal system are different. So maybe we need our own study in our local context to listen to the silent voice from our participants. So that's the reason why I would like to focus on this research in our area. So actually, one of my research aimed to understand the perception and experience related to sexual violence among MSM in our Hong Kong setting. So it was actually the first similar study in the local setting in Hong Kong. So in a nutshell, so we recruited 31 Chinese MSMs through different online platforms like Instagram, Facebook, and through the partnership with NGO like AIDS Concern. Thank you very much. And we conducted individual semi-structural interview to gather the detailed personal narrative and insights. And we try to analyze the data using thematic analysis. So we have identified 4 themes based on our study findings. So I will go through it one by one briefly. So in our study, the first theme is emerged as the recognition of the various forms of sexual violence of MSM. in Hong Kong, so ranging from physical to virtual ads. So a particularly disturbing trend we uncovered is the practice of stealthing. So an ad, as I mentioned before, where an insertive partner non-consensually remove a condom during a anal intercourse without the consent of the bottom. So one participant revealed that, okay, his partner has initially agreed to use a condom. However, despite this agreement, the participant later discovered that the condom has been removed intentionally by his partner. So such experience underlying a concerning belief among our participants that bottoms are particularly susceptible to stealthing. This vulnerability is actually attributed to the difficulties in monitoring consistent condom use throughout the sexual encounter due to the nature of certain sexual positions. So a deeply concerning sub-theme that emerged from our study is the issue of forced camsex. So participants also share harrowing experiences of being pressured into camsex, despite the clear refusal to engage in such acts at the very beginning of such sexual encounter. So this highlights a troubling aspect of coercion within the community that extends beyond physical force and to the substance-induced pressure. Additionally, concern about the inclusiveness of hotels, the LGBT friendliness of hotels is another issue. So this apprehension had led many LGBT members to seek more anonymous venue for sexual encounter, such as gay sauna, for example. However, these settings also have their own risks. For example, some of our participants expressed that because the rooms are very dark, it is very difficult to detect whether a partner has removed the condom or not. So this experience, as conveyed by many of our study participants, underscored the alarming risks associated with sexual encounter in specific physical venues. So a further alarming issue identified from our research is the non-consensual sharing of intimate photos or videos. So our findings indicate that there is a high preference of unauthorized videos and photos from sexual encounter being circulated on different online platforms like Tumblr or Twitter. So participants have recounted distressing instances where sexually explicit images themselves were distributed without their permission by their ex-partner or the current partners. So furthermore, participants have discovered altered version, photoshopped version of their photos with some misleading captions spread on various online platforms as well. So this image often serves as a tool for coercion used to pressure individuals into performing sexual acts or entering into a relationship against their own views. So the second major insight we have gained is about the intense emotional struggle that come with being a victim. So people who have had to deal with the forced sexual experience share a very deep pain, terror, and worries they went through. For MSN in the Hong Kong society, so the pain is often worsened by the negative views they face, whether it is at home, at work, or even within the medical care system. The fear hit even harder when it comes to the risk of HIV or other STI infections, other the incident of sexual abuse. So the harsh judgment about being MSN get tangled up with the fear about the HIV infection. This creates an incredibly tough situation for those who have survived sexual violence as well. One person actually told us that, okay, they feel extreme panic over the possibility to getting HIV after the sexual violence incident. What made it even scarier was that his family didn't know actually he's gay, so the thought of having to come out about his own sexual orientation and to deal with an HIV diagnosis feel like it is a very impossible task to manage in his life. So participants has also shared serious worry about their reputation being damaged in the gay community because their image was shared without their permission. When this image get out, along with the mean comments and other false information, it's not just a violation of privacy, actually. It's also bring them unwanted attention and a bad kind of fame. Yeah. And also, the fallout from this kind of exposure is quite serious when these private images are shown to family members or even co-workers. So without their permission, it can lead to being treated unfairly and harsh judgment in both one's personal life or their career. Take, for instance, the heartbreaking story from one of our participants that his sensitive photos and personal information were sent to his brother on Facebook. So this caused a lot of embarrassment within the family. And to make things even worse, so this same set of photos were spread around the workplace and with false claim about him getting HIV infections. So because of this breach of his privacy, his boss made him to get an HIV test. And if eventually his contract renewal is failure, so you can see that how damaged it can be from the personal life and career life for the victim. So this story highlights just damages privacy breaches can be for the member of the MSM community in Hong Kong. So this can get hit hard in their personal life as well as in their career, showing a clear need to have better protection for privacy against and also against the discrimination. And the third key theme we uncovered is that there is a bit of, it's quite different from previous themes, is that some people may think that, it won't happen to me attitudes during the sexual violence among MSNs. Some guys we talked to thought that sexual violence is pretty rare in the community and didn't really see it is something that could happen to them. So a lot of, some of them feel that, okay, when it happened, they are strong enough because they are both men, I should be able to fight back as well. And this guy also feel pretty confident that they can stop the trouble before it starts, either by standing up or escape from some dangerous situation in gay sauna, for example. So they hold the view that they would not fall victims to any non-consensual imaging or video taking as well. So as there is a common belief, if someone tried to put something like that, it would backfire and ruin the perpetrator reputation in MSM community as well. So it is a very different view from what from other participants. So the fourth theme we identified related to the proactive measure and tactics people try to use to avoid sexual violence they may encounter. Those we spoke with have described tactics as taking specific precautions, like being very careful to pick places for sexual encounter they believe as lower risk. For example, they think that, okay, going to a hotel may be safer because the lighting is better and it is impossible for them to install the hidden camera in advance, better than go to sexual partner's home because you never know whether they will install the hidden camera in advance. So therefore, some people may suggest that, okay, it will be safer for them to rent a hotel and go to have sexual encounter to prevent any image-based sexual violence happen. And to tackle the risk to the picture being spread without their approval, many have gotten more cautious about how much personal information they let slip on the internet, or maybe they will change their photo sharing practice. They may just share same set of photos, so in case it's leaked out, so the damage can be minimized as well. So even though some people are trying hard to stop sexual violence, unfortunately, many people think that it is very difficult to prevent sexual violence because it can happen in so many different ways or situations. And actually, sexual violence can take different forms, like physical sexual abuse or even image-based sexual violence or technology-facilitated sexual abuse. So making things worse is how people often see sexual violence. The shame can stop victims from seeking help from police or other authority. So sometimes the law in Hong Kong does not really treat certain harmful acts as crime. If one participant said that, okay, she tried to report what happened to the police, but the police didn't think it was a criminal offense. So he was advised to handle it through a civil dispute solution by employing a lawyer. So that's another issue that some victims encounter. And unfortunately, because of the legal system in Hong Kong, actually cannot protect the victim of sexual violence sometimes. So our study highlights the deep-rooted stigmatization and discrimination within our society can significantly hinder Chinese MSN who suffer from sexual violence from pursuing support. So healthcare profession and like social worker and educator actually has to be more informed and sensitive to such idea. This should create a more supportive environment that welcome open discussion with sexual violence with male client as well. And also, it is very important to have a more inclusive and comprehensive care for survivors of sexual violence, like screening for sexual abuse, managing STI, provide pro-exposure prophylaxis, immediate medical treatment, and importantly, psychosocial support. Because based on our study finding, the psychosocial impact of sexual violence is very, very substantial among our MSM populations. So if you are interested to know more, then you can refer to this paper because the finding has been published here. So, and the second part and very short part is about my ongoing study about technology-facilitated sexual abuse in Hong Kong. So I conducted this study because based on my previous study, is found that image-based sexual violence and technology-facilitated sexual abuse are emerging and become more and more prevalent. So that's why I applied for the grant from the government and support this study. So there are two parts of this study. The first part is also a qualitative study to gain an in-depth understanding of the perception and experience of TSFA among MSN in Hong Kong. And the second part is a cross-sectional survey study to estimate the prevalence of TSFA victimization and perpetration and their psychosocial correlates. So it is very super important that our study, normally when you try to read Google or read the paper, most academic study only focus on victim. But in this study, one academic merit of this study, we also try to recruit, although very difficult, to recruit the perpetrator because we want to get an overall picture what happened. We also want to know the motivation and why they would like to do it. So that's why in our study, we have recruited 3 groups of people. One group without any sexual violence experience, and one group is, of course, the survivor of the sexual violence, and another group is the perpetrator as well. So based on our very preliminary findings, so it's the common theme from different group of participants also find that sexual violence is actually a very, very common issue in the gay community. However, there is a common problem where people don't always take this issue as serious as they should. And when sexual violence happens a lot, it may also make people think that badly about the gay community, affecting the overall LGBTQ+ movement in Hong Kong as well. And also, there are also big issues with people not seeing all the different ways of sexual violence can happen. Things like sharing someone's private picture without consent or stalking someone online does not always get recognized as one form of sexual abuse as well. And also, when someone talk to some people think that, okay, sexual violence can't be avoided because it happens so often in the gay community. They said that because casual meetups are pretty common in the LGBTQ community, so there are more chances for sexual violence to happen, especially when people don't behave ethically. So many people also feel that people who do this thing often don't get punished. So it is really hard to make rules to stop it. This means people feel that that's actually hopeless for stopping sexual violence. So it is actually quite sad what happened in Hong Kong. So we also try to understand more about the perception of people with no such experience. So they think that they have been careful enough to avoid it, and they take every step to stay safe. So they don't expect sexual violence can happen to them. So, but unfortunately, some may also blame the victim partially. They may think that, okay, it is because victim maybe partially can be blamed because they did not protect themselves and careful enough. They should not take picture. They should not share their private picture with others. If they don't do it, then it will not share. So some of the MSN participants also think that the victim partially is responsible for such acts as well. So people in our study, for those who are the victim or the survivor of sexual violence, they have a very strong feeling of betrayal and make them have a very strong anger. But however, they think it is very helpless. They don't know what they can do, and they just suck it up, and then they think it is really out of their control. Another very not interesting but surprising finding is that some victims may think that, okay, they are being victim because they are sexually appealing. So that's why, okay, I'm so hot and sexy, so that's why people will abuse me. So I think it is also very surprising finding emerging from our preliminary data as well. So for the perpetrator, so some of them, of course, know what they are doing is actually wrong, but they feel a strong pull to do it anyway. Yeah, they just want to do it. Yeah, and there are people who will stop this behavior if they have also faced the same consequences of what they did. For example, like they need to face some potential legal consequences, or they become the victim suddenly. Yeah, so if they have such experience, may also make them think twice about their action as well. And of course, there are also some people don't think their action as a problem. So they may take, for example, like, okay, just sharing, retweeting a private picture is not a big deal. I'm not the originator. I'm not the one who take the picture. I just share it. So they don't think sharing it may also constitute certain kind of harm to the victim as well. So in our survey, a quantitative survey, so because it's still an ongoing study, so we only recruit a small number of the participants so far. But surprisingly, so we find that almost 90% of our participants has experienced sexual violence, at least one on online platform. Maybe they have received some sexual message or picture they did not ask for, or people making sexual requests they are not really comfortable with. And nearly 4 in 10 participants report that their private photos were shared by others without their permission, but either by current sexual partner or ex-sexual partner as well. And around 3 out of 10 mentioned that they have been through sexual abuse in person with someone they met online, like dating apps like Grindr or Jetty, for example. So it is very important to teach the public more about this issue. People should be more educated more about what constitutes sexual violence and its potential consequences. And of course, we need a strong legal framework to regulate this issue in order to stop people from becoming a perpetrator as well. So we need to work together to listen to those who have been silenced and unite together to against all this abuse. And our main aim is to make online space safe and welcome for everyone, no matter their gender and who they love. And our rising awareness is just the beginning, and we have to keep active steps to ensure that everyone is treated with respect and safe on the online platform. So that's the end of my presentation. And if you are interested, you can feel free to reach me out through Twitter. So thank you very much. Yeah.
Thank you, Professor Edmund. So now we'll invite our special guest from Thailand. So our next speaker is Mr. Siripon Sishie. Okay, so I have a challenge reading all the names for the last panel. Okay, so his topic will be utilizing social media and online platforms to promote sexual health and well-being. Siripon, we also call him ARM, served as the Digital Key Population Engagement Officer at AppCon, focusing on testbkk.org, the campaign. So I'll hand over to ARM to share with us his work.
Good afternoon, everyone. So I think that everyone not too sleepy to listen to me, right? This is the clicker. Yes, so come to my campaign. I'm Arm Siripong Sisha from AppCom Foundation. And yes, Test BKK is from the very big campaign in for this Southeast Asia, that is testxxx.org. So we will come through a lot of slides today. Yeah, we got, I have 90 slides. Wow. With how many minutes left now? 15 minutes, I guess. 9 minutes, wow. 9 minutes with 90 slides, so 10 slides in 1 minute. Yeah, I can do it. So testxxx.org is powered by AppCom. And yes, what is AppCom? AppCom is the organization that want the world where gay men, MSM, and SOGI people can fully participate in and achieve sustainable development in all aspects of their health, right, and well-being. And we work in 3 pillars. The first one, community engagement, advocacy and research, innovation and education. So Test BKK is fall on the 3rd pillar, that is innovation and education. So AppCom work with the country in Asia Pacific, around 30 countries. We work with community-based organizations, the government, UN office, WHO, and USAID. So let's come to my campaign, Test XXX. Test XXX is the demand generation strategy. The trailer campaign meant to do the behavioral change communication for MSM. So the objective of this campaign is to mitigate service delivery gap and barrier. It increase HIV service uptake in each of country. We complement existing HIV intervention program, and we boost essential programming elements and innovation intervention. And the first campaign of Test XX started in Bangkok. So we have Test BKK there. And after that, we have the replicate of this campaign to other countries. We go to Test SGN Saigon in 2016, Test MNL Manila in 2016, Test HKG, Test JKT, Test JOG, and Test 4UB. And the latest one is Test VTE, Vientiane in Laos. So this is a city-based campaign, like in the capital that we know, right? In each of capital, we have the high prevalence of infection of HIV in each country. So this is the Test XXX family that are now operating in each of country. We now have 4 countries in Thailand, Indonesia, Mongolia, and Laos. So we have more 4 countries to come. We will have Test, maybe Test Mumbai or Test Delhi It's up to them to decide what name they want to use. And in Nepal, Taste KMD, Taste Kathmandu. In Philippines, they will restart the campaign again as Taste MNL. And in Vietnam. So for Taste AX, we have the same of voice. We resonate our voice together with like the color that are our identity. As you can see, we have like the tag branding here. For Bangkok, it's very like, oh, the city that's very vibrant. MSM can be like everywhere. So we use the word like suck, fuck, taste, repeat. And it's easy to remember, right? If you have like any risks, like to suck, to fuck, yes, you just come to taste. And then if you do it again, repeat it. But for Taste Saigon or Taste JKT, in each of country, we have like cultural sensitivity. So these line tags have to change, adapt to their cultural. Like for Taste Saigon, it's go to top but taste repeat. Or in JKT, fun, love, taste. If you have fun, yes. If you love someone, you go to taste. And then repeat if you have the new one. Okay, so for the main activity in Taste XXX, we have online outreach. We have like a lot of channels. We have Facebook, IG, YouTube, TikTok, Twitter. We work with KOL or influencer to spread the educational material. And we have like the online advertising for the social media as Facebook or Google Ads to leverage the campaign to reach more people, and also work with gay dating apps also in order to like buying ads and put the ads on the apps. The next activity that we have offline outreach, that the key community events that like happen in the nightclub, the party, like that. And we do the partnership with MSM Friendly Clinic to provide like more place and more service to our key population. We have the monitoring and evaluation that up to the key performance indicator from like data from our clinic partner, like reservation and service uptake number of offline engagement and online engagement. And yeah, at last we have campaign assessment, that is baseline survey and follow-up assessment. And this is the website of Taste BKK. And it's applicable on mobile view and desktop view. So for our Taste AX family, we have like the key to make our campaign success is to make to be sensitive, to be open wider is better, and be versatile. Like no need to be top or bottom. Yeah, you can be both. You be versatile. So the first one, be sensitive, because like people nowadays, we love the story. We love to see the thing that is our story, right? So in the marketing every day, we can see some kind of storytelling. If we can find the personal touch to the thing, to the campaign that we want to deliver to our key population, it will get more interesting. And when they got some of that knowledge, we can give them some basic consultation and refer to the service. And next, be open. We collaboration with social media influencers for them to help us spread all the knowledge that we provide to normalize all the content about sexual health. And we deliver the activity to the key population. And yes, it's the best way like to engage them with our campaign and close the gap. And next one, be versatile. We develop our content up to their specific preference. Like if they are chemsex, people living with HIV or young KP, they have like the specific need for the content, right? And the thing that they need to know. And we give them the information that suits them and prove that it's useful for them. We cannot give like everything to them because like it's no need to them to know all, right? And yeah, last year we had the community summit that is like the very, very first time that our Taste AX family used to like see each other in person together. So if you can see, our brand is resonate to each other. This is Taste JKT. You will see the media. Compared to Taste VTE and Taste BKK. It look by brand, it look the same. We have like the resonant sound to each other. So now, let's go a bit deeper to Taste BKK. For Taste BKK, we focus on 6 key goals. The first one, we encourage our key populations for using a condom every time or as much as they can while they're having sex, and get regularly testing for HIV and STI, get access to PrEP, PEP, or ART, and the information safely in sexual drug use or chemsex, the idea of U equals U, and reduce stigma of people who live with HIV. So this is our 6 key goal. Taste BKK don't have our own clinic, but we do partnership with clinic partner in Thailand. We have CU Buddy Clinic that they focus on youth. We have RSAT, Rainbow Sky Association of Thailand. We have Swing that are based in Bangkok and can reach a lot of LGBTQI people in Bangkok. We have CAMAT and M+ that in the northern of Thailand. And also we have Thai Red Cross and Safe Clinic that are the private clinic, Pripta and Tangerine, that can provide to like each specific key population. And other partner that we have, we have Love Foundation that provide us the platform for booking. So that means for Taste BKK, our only task is to communicate the thing, to promote our clinic partner and reach to the people in online. We have Gilead, Veep, Durex that support us for like condom in our campaign. We have Grindr and Jack D in order to support for ads in the apps. And Taste AA campaign supported by Elton John AIDS Foundation. So for our website and social media, let's see. This is our website I just showed you. It's got like some essential knowledge that for like MSM in Bangkok need to know, like safe sex, HIV self-testing, U equal U, drug use and health, STI, get test or party pack. Yeah, I will show you next. And this is, and the last one is sexual consent. For in the website, we also have the educational blog that I keep the tone to be catchy, sexy, and trendy. So this is the content that I made on the website. As you can see, it's not the very like big thing that we talk like HIV self-test, the STI, because all of this content is from the people that are really our key population. When we talk that we are not top or bottom, we are not versatile. I just enjoy to have somebody and just masturbation together. And they ask me, are they abnormal? Is there abnormality in them? I say no. And I find some content that can answer their question and link them to the service because they are not both top and bottom. They are size and tell them like, what are the risks to be side? Like, is there something that they should be concerned, like consent in having sex, or if they're doing side to the partner, is there any risk to get STI like that? Or something that is very deep in gay Bangkok style, like outdoor, that I didn't tell them like where to go and have outdoor, but tell them the risk. When you go to outdoor, what will you bring with you? What are the risks that will happen? The police, the STI, the mosquito, the weather, some kind like that. That like healthcare professional cannot provide them, but we understand as I am one of the key population like that. Next one, some content in the blog is a bit trendy, like how to hook up in Taiwan that I do last year at the Taiwan Pride, that a lot of Thai gay goes to Taiwan and they want to know how to get the guy there. Or like last 2-year content, like to have safe sex in COVID time. Next is our media. Yeah, we have like a lot of our social media channel on YouTube, on Facebook, Twitter, and Instagram. And the total number of our followers is around like 180,000 followers for all platforms. That means like if we share some content or some campaign, yeah, we can like reach to a lot of people. And this is what our content on social media look like. For Facebook, if you got some statistic, we know that when people got to Facebook, in each of posts, we spend time just only like 3 seconds. That means it have to be like short enough and interest you enough for you to read, right? For you to spend your time with it. Like the first one that I just kept it from the gay dating application. In Thailand, they ask like, are you high? And it's Hai. Hai is the name of artist, the country artist in Thai. And I sent her picture there. Are you high? Yes, I'm high. Like that. And I can link them to the service of like clinic partner. If somebody asks you, are you high? What high mean? Like, is that high fun? And on the next one, like the sausage picture, I do it to like compare to the symptom of gonorrhea. That when the first glance that you see, oh, it's a cheese bite. But yeah, for the description there, if you don't want your penis to look like cheese bite, go to the clinic, and it can catch the attention. So the next one is our X or Twitter. This one is quite like the very big platform, and I use it very often because like there are a lot of my friends. There's KOL. KOL in Thailand in Twitter, as you know, we have like a lot of our adult content creator or the people that make porn in OnlyFans, and they are all my friends. They know me, and I used to be one of them, yeah, before. Nowadays, so. Okay, so that means I can ask them to share the picture, and they can help me to share the content that I made on X and Twitter also. And this is the Instagram. I use it like the two purposes. The first one to share like the short video, to make it like the series for like easy to digest video for them, like 60-second video, or to share our cover of the content that we did in TestBKK website. And yeah, we got like the very historic clip here, a lot of clips that we make. Oh, is that short video. And the most famous one is a story about sex worker in Bangkok. This is a variety show that we used to make with the influencer in Thailand that got like a lot of engagement at that time. We have 1 season of our reality show, Delta New, 2 programs of our TV show. The first one that happened on the van, and another one is Gay Games. And this is a famous one. We have 2 seasons of series. That is Gay OK Bangkok Season 1 and Gay OK Bangkok Season 2. It represent like our real life story. It's not like series Y that Thai people really love. It look like boy love story. But this one is quite dramatic. And yeah, it's still like the best gay movie that share in every year. And we reach to like, if we want to reach to the young key population, we have 6 chapters of comic also. So that's all the online activity that we make, and we can like link the people online into the offline, link them to the service. And this is the activity that link the offline to online service again. So we go to the party, like G-Circuit, like White Party, and we be there, give them the thing that we call party pack, provide them some HIV self-test, and yeah, in every party we bring some QR code to, and they can scan and get to our TestBKK line that can get the consultation if they want. Yeah, and it's me. And next we go to the nightclub, Fake at Ratchada. That our key population goes there like in Friday night, yeah, a lot of people. So we make the activity to give the giveaway like the fan, condom, underwear, and also wristband that show at your bottom, your top, or your versatile. And it's really popular there. Okay, and this is the highlight, and I bring it with myself today. That's Safe Play Pack and Party Pack. Last time, Midnight showed you this kind of thing, right? The very small pack. This one, this bag. Inside, we have like 16 condom with lube that you can request it like easily on online, like in Google Form. So this is the poster when I post it online. For each month, we can like distribute 250 to 500 Safe Play Pack. And one more purpose that I discovered recently is if we give them like the free, if we give something for them free, we can request them to do the survey. That is very helpful for me, like to develop the campaign or develop like the service. Okay, and we collaboration with some guide tour, like gay tour. Yeah, they have like the bus and goes to another province. And yeah, some of the tour, yeah, they have sex in the night time. So I provide them the Safe Play Pack also. And this is the new one, that is Party Pack for XX Party. I will show you. In one party, as you know, in Thailand, we have this kind of party like every day, from Monday to Sunday. And each party got like 20 people to 100 people. They book the hotel, like 3 room or 4 room that can live together, and this kind of party happen. So I approach directly to the host of the party and give them the party pack. In each party pack, we give like a very big box of condom with 100 condom. Lubricant, yes, together. And some party, as I realized, some party got some BDSM play, so I provide like sexy underwear for them, like this, and it's supported by Andrew Christian. And the next thing that I just add is HIV self-test in each party, like 2 or 3 if they want to use it or give it to the participant. Yeah, that's all. Oh, and also like the small shopping bag, in case of like if they have the condom that didn't use yet, they can bring it back home. So after I give them like this kind of thing, what happened? They help us to share it on their social media. As you can see, the picture was taken by the host of the party and share it on their live group. And this is the sticker that I put it on every box that they can scan, and if they need some consultation, yeah, they can ask me in line. And this is a picture from the party. The right picture is from the BDSM party that I give them the underwear. Okay, and the next thing we have the school pack. We provide this thing in like sex education in school. There's some kind of like occasional day that this thing happen. So I work with Ministry of Public Health, Department of Health, and Department of Disease Control to get the material. And yeah, on World AIDS Day, we go to the school because like the golden time that we can go and teach them directly for this kind of thing about the prevention. And I'm happy that condom is very popular at that time. Like youth can get it without any judgment or stigma. And goes to our secret, the strategy and tools that we use. I will go it like very shortly because like I'm out of time now. For the strategy, I combine these 3 tools together. It's been like a digital marketing tools and marketing, and also the copyright tool. The first one, POEM model. Have anybody used to hear it before? No. Okay. So POEM. in our nowadays world, in digital world, there are three kinds of media. The first one, owned media, paid media, and earned media. Owned media, that is the media that you can operate by yourself, like 100% own it. Like your website, your Facebook, your Instagram, your employee, your talent, that's your own media. For paid media, it's the thing that you pay your money and get that media spread widely for other people. And earned media, when you have your own media and people give something to you, like if you post the video on YouTube and a lot of people watch it, you get some money, right? That's a kind of earned media. But on our way, if people share your content, share your media, or made their own content from your content, we call it that earned media. So let's see. This is an example of paid media, owned media, and earned media. You will see the intersection here. If your own media have to be like earned media, you can do some share requests to the KOL for them to help sharing. Or if you put your own media and put some money on it to be advertised, it's sponsor post, right? Or if the paid media goes to earned media, if you paid the money for the influencer to do any content for you, yeah, it's sponsor influencer. So this is the example that I can show you. Let's steal some time, right? Okay, yeah. Okay, so for POM model that I just showed you, this is our own media. It happened like last year, the PrEP provision in Thailand, for your information. Last year, our PrEP service had to be stopped as the government announced that it's illegal because our community clinic had no doctor, nurse, or healthcare professional that was trained by Ministry of Public Health. So yeah, we have to stop the service for a while. And then I decided to make this campaign about PrEP provision in Thailand. I made it as a series of picture and trailer the message that very, very easy and simple one. As in Thai is PrEP must be accessible. This is the first tag that I use. And the second one, don't stop distribute PrEP. It's like the word that tell the people like what to do and what happened to their life. It's not just only like for our key population, right, that need PrEP, but what does it mean? It means like we need the right to our health. We used to distribute PrEP freely before, like 10 years, and then government announced that we cannot. So we emphasize this kind of thing by these two taglines and made it as a series by our own media. And then what happened next? From our own media, we got some earned media back from our community, like Swing, ARSAT, IHRI, that they also do same kind of campaign that resonate with our own media. And the next one is the paid media that we do. We do some kind of like lobby on the digital world. We buy some keyword. If you search the word PrEP at that time, it will appear all the content that made by Taste BKK or our clinic community. And you will know situation like what happened in Thailand. Like the government tell us to stop to distribute PrEP. And yeah, as you can see, if this kind of three things works together, I just use only 7,000 baht for promote this campaign on Google. And it can reach the people like a lot. And a lot of media and press come to do the interview with our clinic partner. And this is like the result that show for this campaign. Because like, yeah, we need some action for them to do. I set it in the change.org for the people to sign their name, to put their name on it. And just only in like 7 days, we can got a lot of name signed. And what happened next? We can send the letter to Thai Parliament. After that, the Ministry of Public Health, Department of Disease Control, held the meeting for community partner, like how to mitigate this problem. And after that, just only like 1 month, we can distribute PrEP again. Like we bring our community partner, link them with the hospital, because if they're linked to the hospital, they got the doctor, they got the nurse, they got the healthcare professional that was trained, right? And doing the telemedicine, yes. So another model, we got like 5A model that gain like a lot of awareness to people first. Let them appeal with our content, like the real story, like happened at the time. And they can ask like what happened, and they ask something to put their name on the change.org and do some advocate, like share our content. And the last one, like Ida, if I want to make like a content that that interests people, this is like the checklist that I will do, like to have attention, interest, desire, and action. So it will look like this. The attention, like the picture that can gain the attention, the interest, like what is this campaign, and decide what they can do, and act like what they have to do next, or how can they help us. And so this is the last part, our statistics on Test BKK. We got like 5.5 million reaction on Test BKK online platform. And we can distribute condom and lube around like 67,000 condoms and lube was distributed. We got like 3,000 booking reservation, 2,000 of uptake booking service, and PrEP service uptake, like consult, refill, and prescribe PrEP, 3,700 cases. Okay, and this is the performance of our social media platform. And yes, thank you.
Thank you so much. For the last sections, since we do not have time for the Q&A, so if you have any questions for Professor Stefano, for Professor Wang, Professor Edmund, and also Arm, you can email to me, and I will share the questions and get back to you. Okay, I promise I will get back to you. So I would like now to invite Jerome, our CE, to come to the stage to give a closing speech, and thanks everyone. Thank you.
Thank you very much. I could be very short. It has been a very long day. I think just quickly, I think the whole purpose we're here today obviously is to address disparities in HIV and sexual health. And I just could not emphasize enough is if we want to break service silos, we need to work together, we need to collaborate, and we really need to pool resources together. After all, no one single organization can do all the work. And really, I mean, we need to continue to work so that we can create a positive atmosphere when it comes to all things relating to sexual health. After all, Victorian morality should be consigned to the history books. So before we all head out, I'd just like to give a thanks to all those who show up today. They really made a big difference, and they made this event a smashing success. Also, I'd like to express my heartfelt thanks to our esteemed speakers for sharing their insights, and also I offer my sincere gratitude to our sponsors for their generous support. And last but not least, I just want to give a quick shout out to my colleagues who put together everything. They have done a great job, and credit for such a terrific event goes to them. So please join me in showing our appreciation for all they have done. And on that note, thank you very much, and hopefully we'll see you all next year. And have a great evening. Thank you.